day of our Sickle Cell Foundation of Georgia 2025 Legislative Conference. We have a full day of presentations and panels for you with the latest information on important legislation that we're watching and advocating for. Sickle cell disease treatments, research and therapies, coordinated care guidelines, and many other important topics to the sickle cell community and supporting services as well. If you were with us yesterday, you'll remember Dr. G was part of a panel discussion on the current challenges of federal funding and what it means for sickle cell disease research, treatments, and overall patient care. Dr. G is back with us this morning. For those who don't know her, she's a pediatric hematologist and oncologist with Children's Healthcare of Atlanta. She's also an associate professor in the Department of Pediatrics at Emory University School of Medicine and a sickle cell disease researcher. Frankly, we could discuss Dr. G's achievements, honors, and awards by half the morning. Not to mention her advocacy for the sickle cell community in Georgia, but suffice to say, Dr. G is back with us to talk about complementary and integrative health. It's a research technique used to study real-time microvascular characteristics and blood flow dynamics. But it's not a direct treatment or a specific pain management protocol itself. Researchers use complementary and integrative health to visualize and quantify microvascular abnormalities in patients with sickle cell disease to assess how potential new therapies such as blood flow and small vessels, and to better understand the underlying mechanisms of vaso-occlusive crisis, which are the primary cause of sickle cell disease pain. That's as far as my knowledge on the complementary and integrative health. So I'll turn it over to Dr. G. Dr.
Morning. Good morning. Okay, good morning. Actually, Tabitha gave me credit for my colleague Vivian Sheehan's work, which is in microvascular visualization. I'm talking today about complementary and integrated health for sickle cell disease pain, and I'll explain what that is. I have no conflicts of interest, no financial interest in any of the things I'm talking about this morning. So those of you who have heard about sickle cell disease, we know that there are cells. Red cells have a different shape. They have they look like sickles, which is the curved blade that we use to cut grain. And those cells can block the blood vessel, and that's what leads to vaso-occlusion. So with cells not flowing to the tissues, there's reduced oxygen, and that can be painful. This figure is from the Arthritis Foundation, but it's very appropriate for sickle cell pain as well. The little a says that pain is affected by our thoughts, B, by our emotions, and C, by our sensations. So the brain is the mediator. It's kind of where pain is felt, even though the injury might be somewhere else in our body. Now, in sickle cell disease, the blood vessels can also constrict. Everybody has that happen, like when it's cold. But constriction or tightening of the blood vessels also reduces blood flow and oxygen delivery. And when there's not enough oxygen to the tissues, there can be inflammation. That is the sensation of getting redness or irritation within the tissues that are hurting. And you can see that when you get a bug bite, when you scratch, when you have an injury and it starts to swell up. Okay, yeah, so treatments. What are some of the treatments? Hydration is really important, so just having enough liquid in your body, either by drinking or in the hospital setting, we use IV fluids. Anti-inflammatory medications or procedures can include the non-steroidal anti-inflammatories, so like ibuprofen and naproxen. In the hospital, we use IV Toradol, and some of them you can rub on your skin, so like Voltaren gel. Pain medications affect the sensations by blocking what the brain feels from all the pain. And then some of the sickle cell directed therapies include bone marrow transplant or gene therapy now, blood transfusions, hydroxyurea, and L-glutamine. So stress reduction can help reduce the constriction of blood vessels and also reduce our emotional responses to pain. And then cognitive therapies might affect how we think about and experience the pain. So what is complementary and integrative health? So this slide is from the National Center for Complementary and Integrative Health, called NCCIH, at the National Institutes of Health. And it tells us that it wants us to look at the whole person, not just one thing or another. So in the red circle, we have pain management, but many things affect that, such as the mind-body connection, how we take care of ourselves. So positive health processes might be lifestyle changes, and then nutrition and natural products. And we have many representatives here today who are going to talk about this. So complementary approaches include physical, psychological, nutritional therapies and practices that support the entire body and help to manage pain. And in the older times, even a decade or two ago, we would call this traditional medicine or alternative medicine. Traditional being kind of in the traditions of certain cultures. Integrative care means combining conventional, kind of routine hospital care with complementary approaches to promote the health of the whole person. And then research on this is very important because it's important to prove that what you do actually helps. And so the NCCIH is a big funder of this type of research. But unfortunately, it is one of the centers at NIH which is being targeted for closure. Okay, so what are some well-known ones? You've probably heard of many of these. So they're kind of listed in most favored in the United States. So meditation, yoga, massage, chiropractic, and osteopathic manipulation. Okay, other things include dietary supplements, acupuncture, relaxation, hypnosis, tai chi, and virtual reality. One of our attendees yesterday, Dr. Matty at Emory, studies virtual reality. So you probably are familiar with some of these. So acupuncture is with needles. If you do it in the traditional Chinese medicine way, they do it along certain meridians that have connections to certain body parts. And that can help relieve pain in the back and neck, knee arthritis, headaches, cancer pain, and post-surgical pain. And this is the kind of the medical research backing of these things. Meditation and mindfulness for pain relief has had mixed results, but mostly has been studied for in the setting of trying to reduce the intensity of chronic pain. Relaxation techniques can help with headaches, post-surgical pain, low back pain, and arthritis. Massage can help with certain areas of pain, but in the studies, trials, the effects were short. Yoga can help reduce low back pain, neck, knee arthritis, and headache pain. And behind the black screen, I saw some yoga mats, so you might have a chance to try that out later. And virtual reality, there's now an FDA-approved device for low back pain. So there are a lot of things that are out there. Similar treatments that are like alternative medicines, but are a little bit more kind of hard conventional therapy, is that some physical therapists will give massages, and they might do dry needling, which is also done with fine needles, but not necessarily following the traditional Chinese medicine approach. And that's kind of targeted towards like the areas where we have pain. Neurobehavioral and mental health treatments with psychologists and psychotherapists include cognitive and behavioral therapy, and that's reasonably well studied for a number of painful conditions. So what are some other non-pharmacologic approaches? Relieving muscle aches through massage, warmth, Epsom salts baths, so like really common sense things that people already do. Patches like lidocaine patch or Salonpas, oils or ointments. So many people find these things helpful, but some people don't find them helpful at all. So distracting the mind through entertainment, reading, and meditation, having positive thinking. And there's something called the placebo effect. Sometimes things just work if we believe they're going to work. So positive thinking and placebo effect can help with some things. So anti-inflammatory foods include blueberries, turmeric, fish oil, yams, and avoiding fried and processed foods. And then the last one is not the least important, but having a support system and being comforted by finding ways to comfort yourself and having someone to support you. Okay. So can complementary and integrated practices help sickle cell pain? Maybe. Small studies have shown some efficacy of acupuncture, yoga, CBT, self-hypnosis, massage, and virtual reality. And let's see, where might those work? So they might improve flexibility and muscle strength, such as yoga, and perhaps massage. Improve breathing through yoga and meditation can help your oxygen delivery. Centering your attention may help with your thoughts and emotions. Managing stress will help with your thoughts and emotions also. Relaxing the mind and managing stress can help with your blood flow. So, what about insurance coverage? So we can see on the right, not usually covered, and on the left, sometimes covered. So we start with acupuncture. Many plans now offer at least partial coverage for acupuncture. Medicare covers up to 12 sessions. Chiropractic care is of a sometimes covered type of service, more consistently for back pain. Therapeutic massage may be covered by insurance. Nutritional counseling is included under the Affordable Care Act. It is preventive. So preventive for things that are well known, like heart disease and diabetes. Things that are typically not covered by standard insurance are on the right, so specialized lab tests. So if you're looking to find perhaps a lab panel that will tell you about your hormones or your gut health, you might not be able to get that paid for by your insurance. Supplements and herbal remedies, extensive consultations, so like really having someone get to know you and look through all your kind of holistic health needs may not be covered. And mind-body therapies, not necessarily. What about Georgia Medicaid? Commonly covered integrated services, include a few things here: rehabilitative therapies, some integrated health, and let's see what's it say. AmeriGroup specifically focuses on integrated physical and behavioral health services, but that doesn't necessarily mean it will cover the things that we think that I'm talking about that are called integrative. And then nutritional services may be covered when medically necessary for certain chronic diseases. So the things that are not covered by Georgia Medicaid: chiropractic, massage, acupuncture, naturopathic medicine, and alternative medicine. So what are our legislative opportunities here? We can try to advocate that Medicaid expand coverage for complementary and integrated health treatments, but the insurers will need evidence that these treatments are really and truly helpful. And in order for that to happen, the NCCIH needs to continue to be present and be able to support this kind of research. And this is our team at Children's Healthcare of Atlanta. I'm one of many. People work really hard for working towards the health of our children and families who are living with sickle cell disease. So that's part one. Okay, can I take any questions?
I do.
Okay.
So now would I like to ask, as it relates to nutrition, as it relates to mental,
Is this being promoted throughout the sickle cell community? Because I can honestly tell you that when we are seeing our clients inside of the sickle cell sanctuary, oftentimes no one has spoke to them about nutrition. No one has really spoke to them about alternative approaches to sickle cell.
I would say that I'm going to just speak for myself, my own practice and our team, is that we often don't have time to delve into deep topics. So in nutrition, we're trying to make sure the children aren't obese or underweight. So just kind of regular calories is kind of what we spend most of our time talking about. And then the alternative therapies, many people, we might say, you might benefit from yoga exercises, or you might think about acupuncture, but those are extra costs, so people are not always so willing to get them. We do have some acupuncture in the hospital setting, and people who try it there will sometimes invest in getting treatments outpatient. Any other questions about this before I move on to my second half? All right, so the second presentation is co-presented with the American Society of Hematology. So, I'm a member of the Committee on Practice at the American Society of Hematology. We're going to talk a little bit about what we do there with regard to advocacy. So, I've been on this committee for 2 years and a little bit forced into advocacy because it isn't something that I immediately gravitated towards, but that was just one of the activities that all the members of this committee do. And so here I am in Washington with Dr. Fostepe from Houston. And what we do is we are trying to raise sickle cell awareness, enhance federal activities, protect and advance sickle cell research, improve access to comprehensive high-quality care, and improve reimbursements for all hematologic diseases, including sickle cell disease. So we have the Fight for Hematology program has 4 parts: advocating, sharing their story, amplifying the message, and donations. So first, advocacy. Many of you are familiar with this because that's why I'm here today, but to contact your members of Congress to protect access to care, federal research funding, and the critical federal health workforce and infrastructure. And one of the ways we have that, you can, if you go to our site, you can say, tell your congressperson, how it cuts to NIH will harm research to cures. So this is one of our initiatives, and you can recognize some of the people. Okay, so taking action. So what about saving Medicaid? So we, last year in April and May, we went and we were opposing the cuts to Medicaid. So Medicaid policy timeline, we kind of learn about all the parts of it, and then we go and we visit the staffs of our congresspeople and senators to advocate for certain things. So here, making noise, so writing letters, going to rallies, all of those things are important. So being seen, visibly seen, and sending messages to the people who make decisions. All right, yesterday we talked about the Sickle Cell Disease Comprehensive Care Act. If you weren't here yesterday, just go over it briefly. It allows states to have an amendment plan so that for Medicaid funded individuals that they can have a medical home that will coordinate their care and hopefully keep them healthier than sporadic health care or emergency visits. And the funding for that would be up to 8 fiscal quarters or 2 years of funding to pay for the medical home services up to 90% to the states. All right, why is this important? Medicaid is a major insurer of people living with sickle cell disease. And the current medical homes legislation requires that a person have 2 chronic diseases. And in this case, the sickle cell alone would qualify as a condition. And so this could be very helpful, and this is one of the few things that has bipartisan support and the support of both branches of our legislature. Okay, so if you're interested in this, you can scan the code, and how can you help is you were to write letters and communicate with your congressmen, congresspeople, and senators. And then there's the second one that we've been promoting this year is the CMS access to cell and gene therapy. And what this is for the states to help negotiate good contracts with the gene therapy companies to get kind of the best possible rates for gene therapy products. So currently, I think this number is up to 35 states have signed agreements with CMS to join the access model. I've heard that Georgia is doing its own contracting and not participating in this. So we hope that the state was able to get good rates for our constituents. So that's about our advocacy work at the American Society of Hematology. And that's it. Any questions?
Are you seeing any changes? Are you seeing any changes in the cell space with, by being a part of ASH? Do you see any comprehensive
Changes that we can all say, because we now have action, because they're advocating, here's the change that I've seen inside the social space.
I think there's been more movement on the Sickle Cell Comprehensive Care Act. That's been around for a few years, but if they see us every year coming into their office talking about the same thing, I think as we heard yesterday from Representative Crawford, kind of being the squeaky wheel being in their face, they hear it multiple times, and they're more likely to move on things. So I think one of the Florida congressperson that we met, he had not decided to join the bill, and after we had spoken to him, he did join as a sponsor. So I think that ASH's work, it's across all of hematology, but their sickle cell work is very effective. Thank you very much.
Thank you, Dr. G, for that very educational and insightful presentation. So next we are going to move on to our panel discussion on alternative and complementary medicine. Today we have with us Dr. Parnell Abraham and Gabrielle Colantes. Dr. Abraham has over 35 years of experience with sickle cell disease education and sickle cell disease management. He has been an advocate for holistic health care for decades. Gabrielle Colantes is the regional director of marketing in Georgia for the Cannabis Dispensary Fine Fellow. She leads marketing outreach efforts across Georgia, Massachusetts, and Connecticut. She's been instrumental in building awareness and access within Georgia's state medical cannabis program. Please give a warm welcome to our panelists. We don't like it. So thank you both for being here and speaking on this topic and sharing your expertise today. First question is for Dr. Abraham. Let's start with what exactly is alternative medicine or holistic care? And is that the same thing or is it different?
Well, basically, it is kind of the same kind of parallel. With holistic healthcare, you're looking at the entire being. So you're not treating the symptoms only, you're looking at the entire person. Because someone could just have a headache, you're not just going to take the time to hold emotion, but then you address, well, what's been going on in your home? What's going on at work? Because there's many factors that may be triggering disharmony in the body. So that's the part of holistic care we have to look at. Now, I tend to specialize in something called kinetic medicine, which is originally from Egypt. So therefore, you start with the spirits. You always start with the spirit, because the spiritual bring the material. So therefore, it's always something internal that's triggering the body to manifest something physical. So we have to understand that aspect. So holistic medicine is always the entire thing. You're not looking at symptoms only.
Thank you. Gabby, can you tell us about the different kinds of cannabis products that could benefit sickle cell warriors?
So across the board, there are numerous ways you can consume cannabis. Everybody has different preferred methods. Not typically, in the state currently, what is allowed are a range of essentially gummies, capsules, which is cannabis in powder form, encapsulated. You can get tinctures, which is what you typically think of when you hear low THC oil, right? Like the oil that you put sublingually, and then you can do topicals currently. So depending on your stage, right, if you're in crisis or not, we do also find a lot of warriors who utilize inhalation for breakthrough pain, just depending on their situation and where they're located.
Dr. Abraham, tell us why you've been advocating for complementary medical care for so long, and what was it that sparked your interest in it?
Well, my interest in holistic care started really from my household. Because I remember my brother and I growing up in Haiti, where we did have pain episodes, but we weren't on any medication at all. Especially for me, my routine was once a year we get a detox, and if I had some mouth pain, I remember my grandmother gathering different herbs, boiling them, and giving us a bath with this, and that would take away your pain. So that knowledge had always been there for us. So when we came to the United States against doctor's advice, because I was advised, my parents were advised, both my brother and I, because we have sickle cell disease, will not survive beyond 18 years of age. So hearing that news, my mom was like, okay, that's fine. She took us here anyway. My brother unfortunately passed at 46. I just turned 56 and I'm still here. To me, that's my primary motivator because I know it can be done. You can't manage sickle cell disease and many different health factors in a natural way. So that's been instilled in me. And after volunteering with the Sickle Cell Foundation of Georgia, I had met Phil Oliver, who was a genetic counselor, who actually took me in and kind of like really started teaching me about herbs, about alternative, introduced me to Dr. Sadie. I mean, people really in the natural health industry. So that was my primary motivator into not only teaching others, but to get the word out. Because action and vision are stronger than just theories. So when I'm sitting somewhere, standing somewhere, speaking, I'm speaking from a place of experience, not theory. So when I share things with individuals with sickle cell disease especially, and I'm teaching them, and I'm saying, if you want to be where I am, 50 years from today, you will know. So all these children that we saw in the picture with Choa, if they start them really understanding who they are in terms of divinity, and then you add the nutrition aspect and add many other factors, these children will be sitting here at 59, 60, 80. Right now, it's not happening. You know, by the time they get out of pediatric care, very slim chance that they're going to be on 25. So we have to realize that's what's occurring and why all of us need to look at mental health.
Wow, that's really insightful. Gabrielle, you have been involved in legislative efforts that would broaden access to Georgia's medical cannabis program, House Bill 227 and Senate Bill 220. The Senate bill passed but was not acted on in the House before the end of the session. Tell us why this bill is so important and what happens next.
I think a lot of people in this room remember when that initial bill was signed. I see a lot of faces that played an integral part in getting that initial hope, act across the line. Currently, the state is operating under very strict parameters. We are essentially governed by 4 different bodies, largely the Georgia Medical Cannabis Commission Despite that, we're still called the low THC oil registry. So I'm sure you can understand when we're trying to get out in the community and educate people on the fact that this is a legal, viable, safe, state-sanctioned program, it's super confusing to them to hear low THC oil, but what they're looking for is medical cannabis. So that is one of the first things this bill is going to address, would be renaming the program to what it should be referred to, which is the Georgia Medical Cannabis Program. We're also looking to expand more product access because, again, everybody's method of consumption is different. What works for patient A is not going to work necessarily for patient B. So as the doctor, you should have the ability to make a recommendation on cannabis, period. You shouldn't be restricted to saying, sure, you can take one pill, but what's really going to work for you is potentially looking at other programs, right? I think there's a lot to learn from successful programs in the Southeast specifically. I have been dealing with markets across the United States, including Mississippi, who's been selling flower and vape for the past, 3 years at this point? So to see that our bill was signed close to 10 years ago, and we're still in a place where we're treating end-stage people, right? It's already very challenging to get a card, and then when you do get a card, your relief is oftentimes limited because you are having to wait for your medicine to kick in. It's awful to be in crisis, whether you're a sickle cell warrior, whether you are a stage 4 cancer patient, whether you are somebody who struggles with chronic pain, and you have to wait an hour and a half for your system to receive this medication, when you could look at somewhere like Texas, who just has the ability to essentially, they're gonna start rolling out vape based off of milligrams, right? Because everyone's situation is different. So we can expect expanded product access. We're gonna rename the program, and we're just gonna work to continue educating people, because right now we're essentially working with our arms tied behind our back, in terms of, we know how, physicians spend so much time in school learning what they learn. By the time you have been practicing for 25, 30 years, to have to go learn this entire new program that the state is not helping you with, right? They're not offering any current, CE credits or anything of that nature. This is a very easy fix that we could look at the accomplishments and the drawbacks of other programs, and we can essentially get a perfect program for the people who need access in our state.
Thank you. So now I have a question for both of you. I have heard two different ways of basically saying the same thing. There's more than one way to skin a cat, right? So what are some possible downsides to cannabis use right now? As we state with lawmaker laws and things of that nature, what are some of the downsides of that?
Okay, so I will start with, I think number one is the fear. There's a lot of misconception about the term cannabis. And a lot of people are more familiar with the term marijuana. So marijuana is a purely negative term, racist term that is used and actually used to criminalize people. So therefore, when you talk about an item that is criminalized like that, so the downside of individuals, especially people working, let's say with corporate America, or nursing and stuff like that, so they're reluctant to take any of these products because people are afraid, hey, what if they test me, they'll fire me? What if something showed up or they smell something on me, they're gonna fire me? So I think that's the number one thing we need to look at, the stigmatism that's around cannabis and fix that. Me personally, I think any downside would be I sleep too much. So if I'm in extreme pain, I sleep too much, which is the same thing morphine does to you. You go to a hospital, they give you morphine, they knock you out. Morphine is used to knock out elephants. So if it's gonna knock out an elephant, most human beings will get knocked out for morphine. And that's the standard protocol. You get morphine, you get your IV and everything else. But I think to me, that's my most worst experience, that I sleep or I wake up a little hungry after taking my cannabis, but that's not. And I think one time I took a cannabis capsule and I was in pain for almost 3 days straight, nonstop. And I took my capsule And I actually slept for 2 days. But again, that was in the last day. It was not like I was gonna go into a coma or anything like that. So we have to address the stigmatism and the fear with cannabis.
Gabby?
Definitely sleep too much, you take too much. I think that's a crucial thing, right? Because people don't have the information that they need. So you're going to places that you don't know where they're getting their product from, right? And you are not getting particular instruction. And we always say, start low and go slow because it is medicine, right? So any product that you're getting from a reputable source, such as a state-sanctioned dispensary that is essentially as close to farm to table as you can get. Why? Because there's a facility in Macon, Georgia, growing all these beautiful plants that we're forced to crush into oil to then create our products with. So as far as downside, the reality is there's just no education out there. So people who are at their end, they're at the point where they're willing to try anything, and they don't have the information that they need to do it appropriately. So then they get uncomfortable with it. You're having not a great time. Like Dr. Abraham said, you could get to a point where maybe you sleep too much and that makes you uncomfortable. So that's one big downside. I would say another one would be trying to, it's in the same vein of doing things without having proper information, because this is also not something, right, that's for everybody. It's like anything else, right? We always recommend you need to consult with a physician. If you are on any kind of medication, if you struggle with any kind of mental illness, right, this may not be a good fit for you. Or it may be, but only a doctor is going to be able to really recommend that to you or have that conversation with you. And when you are not going through safe channels because you don't know that they exist and you don't feel confident in going through them, how can you make those decisions on your own, especially for our elderly, who are majority of our demographic, right? These are people, again, who have seen the war on drugs, have grown up going through the DARE program and had it instilled into their head, this is dangerous, this is dangerous. So by the time they get to this point, they're so embarrassed, frankly, that they are scared to share their experiences with anyone, and then they just go. I have had 89-year-olds call me and say exactly what you said. I slept all day yesterday because you took an entire syringe. It's like 70 milligrams versus just starting slow and going slow, right? So just having that information is a big downside, and I think without that, and you're not addressing your potential mental issues, whatever the case is, that can create a very scary situation.
Thank you. So when it comes to sickle cell disease, we know that treatments are limited. We also know that opioids are prescribed most to help often manage pain crisis. That means sickle cell warriors' risk for addiction are greatly increased through opioid use, and it can have adverse effects on the body over time. For both of you, I want to know, are there other alternative therapies in development, whether with something that my fellow is working on or with you, Dr. Abraham, that things that you know of that could help show promise for sickle cell patients and warriors?
Well, I think Dr. G gave an excellent presentation, but she had a whole list of modalities that can be used. So cannabis is just one thing, but we also have gem therapy, we call that. So that's, in other words, wearing things like certain beads, which kind of go in harmony with your body. So this is like actually blue sapphire. So it helps with concentration, it helps with relaxation. So there's many different modalities we could use. Acupuncture is one of them. We have herbology. We have meditation. Of course, Tai Chi is excellent because I do Tai Chi, I do meditation. There's vibrational therapy, which vibrational therapy is not just going in a room or listening to different sounds and stuff like that. Vibrational therapy starts within. So when we speak things, we actually speak things into existence. And we have to understand when we speak and we're actually creating a vibration in the atmosphere. So therefore it starts within ourselves. So that's why I say everything is spirit. It starts within. So therefore we have to speak healing. We have to speak peace. When we're thinking oh, we gotta fight. We don't need to fight. We gotta go to flow in harmony and learn how to receive things. So that's what I would say is a lot of modalities out there. So, I mean, we could spend all day just discussing different modalities.
I think when discussing cannabis in specific, when it comes to therapy for particularly sickle cell warriors, right? I think there's still so much information to be uncovered because frankly, this has been not allowed to be fully researched to its full capabilities. With that being said, we do already have so much information and research. When you hear cannabis, most people are marijuana, right? You typically know THC, CBD. Most people don't realize that you go deeper, right? There's CBC, there's CBN. These are all powerful anti-inflammatory agents. If you're grabbing something that is more geared towards your sleep, you're probably gonna grab a CBN geared capsule because that is gonna help you stay asleep and go to sleep and stay asleep longer versus if you need something that's gonna be more just full body relaxation, right? Without you having to be knocked out for the whole afternoon, you're probably gonna lean more towards something CBG, CBD, right? So just understanding these distinctions is crucial because it really depends on what stage you're in. If you are just managing your day-to-day functionality and living, you probably don't need as many layers of these cannabinoids versus if you are in crisis and you need to sleep because your body needs to heal, right? That's when we're healing, when we're recovering, when we are able to get sleep. So that's something one of our physicians typically start with. They'll ask, how are you sleeping? Because if you're not sleeping, then like that's the core issue. We're not gonna be able to really address anything until we get you to that recovered state. And then we can work with different modalities, like Dr. Abraham said, of getting you back to that homeostasis using a combination. Could be cannabinoids, could be Tai Chi, meditation, across the board.
Thank you. And this will be probably the last question, and I would like to open the floor for questions. For each of you, what do you hope to achieve ultimately with the complementary medicine?
Yes, excellent question. I think me personally, I'd like to see more people have options, educate people about their options. So people will know that they're not locked into one thing only. And as if you don't do this, then that's it. Option to me is my greatest inspiration for people to see that it's option that we always have options in life. As long as we have life in us, we have options.
Of course, you always want people to have options and alternative options, right? I think that goes hand in hand with equity. I think you shouldn't have to wait until you are at your end stage of watching your loved ones suffer to say, you know what, I'm willing to. I have seen hundreds of people that they don't have an option here. And when you are watching your loved one go through the worst time of their life, you're willing to do anything. You are willing to cross state lines and break a lot of federal whatever laws, right, to make sure they get the treatment that they need. And so the reality is that is not equity. Equity is you having the ability to have, if you live in Georgia, you should have an option to have your medication delivered to you, essentially, right? If you are 89 years old, you'd be shocked at the number of 90-year-olds who are driving their partners, y'all, hours away from their home to go get medication, okay? And it's just like, why? So they can sleep? But if you have access to funds, then these other, let's say, class of people essentially are able to hop on a plane and go to where you need to get the medication that you need. So I would like to see more access to information, which is what we're out here doing every single day. That is the core of how you move the needle, right? That's how you educate legislators, that's how you get information. It's people who have just been traumatized essentially by thinking, either I'm gonna go to jail, my children are gonna go to jail, I know somebody who's been affected by this is gonna ruin my entire life. And then opening up the products, because the reality is we're growing these beautiful flowers that we can't give to you, right? The flower itself is medicine. So it's like, if we're gonna have a program, then let it be a comprehensive program that the patients and their physicians can make a decision on. How are you gonna consume this? What is the best mode of consumption for you? And how are you gonna actually get this? Do you have to travel 2 hours away from your home? Or is there an option to where you can have your elderly grandmother's medicine dropped off at your door, or if you're in crisis, you can have your medication dropped off the same way that you have prescription medication dropped off.
Thank you so much to the both of you. I think this has been extremely insightful and given us a deep dive into just what it looks like to be somebody in chronic pain or going through with sickle cell, and giving us an eye opener on what is going on in the house, and also what are other therapies that we can do. So I do want to open up the floor to see if anybody has any questions. Can we have a microphone here, please? Thank you.
Good morning, Gabby. Good morning, Dr. Parnell. Dr. Abraham. And so, first, are these products Gabby affordable?
Absolutely. The products are all starting at about the $30 price range. Our highest priced product is $100, and that is frankly for a bottle of medicine that you're getting approximately 1,200 milligrams of THC in, which is for our very high chronic pain type of patients. So you're going to spend less than $200 for essentially a month of medication, whereas, we also make sure we run programs weekly, right, for people who do face financial constraints. It's a reality, your insurance isn't covering this currently, but we are also working with leading providers such as LeafWell, such as the American Cannabis Association, so that we can have these insurance-backed options in the near future.
So you talked about, fear, but also what are the protocols in place that a physician can speak educationally about a person's condition and what products they take? Because I think the drawback that we have, if a person's doctor, as you guys know, the doctor is the law for a lot of people. So the doctor is not recommending or educating on what these products can do for them. I feel that many people will stay away from it, particularly people that are in corporate, nonprofit organizations and all that, for the fear of, like you said, being tested, possibly losing their job and all that. And so I guess it's twofold. So number one, what are we doing about physicians' education? And then number two, do you believe in your own opinion, because it's your own opinion, that it's not being offered because of the financial gain from the pharmaceutical companies on the rest of medication?
So that's a great question. They go hand in hand. Absolutely. I'll start with the first part with educating physicians. The reality is that I am not a physician, right? I can bring the information to you, but I would never go to you as a physician and say, I'm going to teach you about this, right? What I'm going to do is put you in touch with my team of physicians, because I do have a network of physicians across the United States that are well versed in all the latest cannabis research, and that is how we get the door open, right? Like, we've had very successful meetings with the director of multiple sclerosis at Emory, right? Across the board, so many different, people can benefit from this, and how do you get them excited and to believe in this is by having their colleagues essentially tell them, look, I have case studies of people that have gone through this type of situation, this is what we did, this was the care plan, and making it physician friendly. Physicians think, as you know, in a very different way. You're trained to think in a very scientific way, and if we are not able to reach them at that point, then you've already lost. So having that team is crucial, and I think from the state side, what I would like to see is a program instilled with the continuing education credits, because as a physician, right, you need to continue your education, and if you have a cannabis sector of it, then you're gonna have to get some type of education on it, and you would be surprised at how people's eyes open. So that would be part A, and then for part B, he's
I was talking about the
Financial benefit of Western Mass compared to alternative solutions.
So that is absolutely the thing, as you can imagine. The reality is that I, as a cannabis operator, right, we don't go to physicians and say, hey, we're gonna pay you X amount to this, is that, and the third. Which is good in a way, because the physicians you work with, are morally in line with us. So it is definitely a drawback when you're running into people who are actively prescribing your traditional heavy opiates and narcotics, because we have seen hundreds of thousands of patients who they come to you months later and they say, wow, I've been off of opiates for 3 months and it's been 16 years of daily use. Hey, I'm off of my gabapentin. Hey, I can leave my house again and I don't need this SSRI anymore, right? Why? It's so many layers to it. Your mental state is affecting how you're healing, right? So it's like if you can't even get your mental state to a good place, you're not going to be able to heal fully. They are SSRIs, right, are another big piece of it that go hand in hand with the chronic pain because you're mentally struggling with the fact that you have chronic pain. So if I get you on the SSRIs and the narcotics, essentially the cannabis is going to start weaning you off of it, and that's kind of a big problem when my Medicaid is cash and check everybody.
It's cannabis.
No, cannabis is not addictive. It is not habit forming. It does not destroy your organs. If you go on the DEA's website and you look up cannabis, it will say, quote, there has never been a recorded cannabis overdose death in history.
I wish I had learned about cannabis earlier. I had a son that passed away from epilepsy, and one of the things that helped with his seizures was cannabis. And we fought for a very, very long time in DC to get cannabis passed so that the individuals that had epilepsy could use cannabis, legally. And of course, it was a whole program that we had to go through. But I wish I would have known about it earlier. I believe that I would have been able to help save my son's life.
I love that you mentioned DC as well, because those are successful programs that have done the work of rolling out programs for their doctors, right? Like, their doctors are forced to go do continuing education so that they can have the latest and greatest. And you get to a point as a physician, right, where it's like you need to make a moral decision of, am I going to recommend this because I know it's best for my patient, or am I going to take the other route? So.
I will address one portion of it, what you had asked in terms of the pharmaceuticals. I think that's a challenge for many individuals looking into complementary care. It's the fact that a lot of insurance carriers will offer a lot of medication for free. But that free is not free, it comes at the price for your organs. So a lot of individuals feel more comfortable, hey, I could just get a prescription from my doctor, I pick it up and that's it, versus you can't go to find federal with your Aetna card and just say, put this on my card and file, because that's not the world we live in at the moment. So that's a challenge where the individual is gonna have to make a decision and say, do I take this prescription or do I take something really to help my body? And that's the educational portion that's very important. Yes, pharmaceuticals work, and I do agree, you do need pharmaceuticals at times definitely for something intense, but not long term. I know people who's on diabetic medication for over 50 years, or blood pressure medication for over 50 years, and no condition you can reverse naturally within 60 days or something like that with herbal formulas. So it's that education that's going to be required. And people are sitting there with that as well. Some people will just say, oh, I don't want to hear it. I go to my doctor, what my doctor say, that's it. And that's okay too, because that's their choice. So I just wanted to share that point.
Good morning. I have two questions, one for Gabby and one for Dr. Abraham. So Gabby, do you feel because we live in a Bible Belt airport, is that why in the old Olive or as cannabis or marijuana is the reason that we have not progressed?
I think culture absolutely plays a part in how the reality of the society we live in develops, right? So culturally speaking, this has historically been a very conservative part of the country. I am still frankly surprised, right, that we are as conservative as we are, considering the rest of the states in the Southeast that have been so active in progressing their programs for the sake of their patients. So it's interesting that you bring that up, because a lot of the conversation we've had in recent study committees, it has actually been people starting to quote the Bible in why this should be accessible to everybody, right? The reality is this has been used for thousands of years. This was not effectively outlawed in the United States until 1937 with the tax law that went into place, right? So prior to that, cannabis was used in medication. And using different belief systems can definitely shroud decisions, right? Because you believe what you're told to believe in a lot of instances. So I think if we can shift that educational aspect of like, this could go hand in hand with having a natural lifestyle and, you know, living a biblically sound life. And a lot of people that I run into in the South, Christians particularly, they are not necessarily opposed, but it is illegal in their head. So because of the legality aspect, it puts them in a moral dilemma, right? And that could resolve a lot of that anguish for people who are willing to try it, but are just frankly a little bit scared to break the law in their eyes.
Thank you, Dr. Abraham. My question is, how do you introduce divinity or spirituality to patients that have never been exposed to that?
Okay, I think the easiest way you start with that, with anyone, is really just ask the first question. Are you alive right now? If you're alive right now, divinity is already in you. Because you gotta have that spirit to move you. Yes, we have a heart, you know, we have circulatory system, nervous system, all the different biochemical chemistry within us. Well, you have to start with the basic. I always keep it simple with people. You have life, that's the start of divinity. Then we start talking about breath. We start talking about breath work. And we start talking about speaking, like I had just mentioned earlier. So this is all divinity. Sometimes we think science and divinity doesn't coincide, but they actually work together.
Okay, and last question.
Quickly, I was wondering if you could compare maybe the process of getting cannabis approved from different states. For example, I'm from Michigan. My late mother had cancer, and this was like 5-6 years ago. And Michigan had just approved cannabis use. And it was literally the one thing that would abate her pain. And we were very grateful that it was available in Michigan. But obviously in other states, not like if we had lived in Georgia, she would have just been suffering. But I'm just wondering from state to state, can you compare maybe the process? What is it that, why Michigan and I think Ohio now, why these states are so progressive and we're still, you know, in the stage?
That's a great question, and the reality is it really is a state-by-state basis, right? So I'll tell you, I work pretty much every state in the United States, every market. It is so different. The one thing to always consider is what stage are we on in our state, right? Because cannabis is medical in any capacity. You don't really ever see a state just say, whatever, throw it all out the window, we're going full recreational. Recreational is the wrong word when we're thinking of use. You're an adult, and as an adult, you should have access to use this type of medication. So I would always recommend, depending on the state that you are traveling in, literally do a quick Google search and say, is cannabis legal in this state? It's gonna tell you if it is medical, if it is adult use, and then if it is medical, there is typically a fairly accessible option to get a prescription while you're traveling, right? Even in even in places like Puerto Rico, right? Puerto Rico has a full extensive medical cannabis program that you can actually, if you're traveling there, get access as a patient through a tourist medical license. So DC, as an example, you can go to DC, you can self-certify as an adult for $10 and you have access to their whole program for 3 days. So every state is different, and it really just boils down to knowing, like, first of all, this is legal. It's pretty much legal in 38 states and 3 territories. So in most states, it's legal. And then are we in a medical portion or are we adult use? Because look at Georgia, we're technically medical, but if you look us up, it's gonna say low THC oil registry. So that's confusing to a lot of people when you're coming from somewhere like Michigan that you have access to flower, and then you come to Georgia, you go to the dispensary and you're like, oh, we've got capsules, right? So just understanding like the difference between medical, adult use, and then can I get either like a reciprocity option? Because if you're a patient in Georgia, there's a lot of places you can go to that your license will work there as well. So that would be my recommendation.
Thank you, panelists. Thank you for all the information that you were able to share with us and for being able to answer some questions from the audience. We really appreciate you having us here. Please give them a round of applause.
so much. And if you have any questions on getting access to your medical card or anything like that, Dr. O at the Sickle Cell Sanctuary does a fantastic job of getting you registered. And if not, I invite you to visit findfellow.com and you can find some options there as well.
Oh, yeah, let me come to this point. So I was so excited when you were probably for many months, many years, and I started using the topical cream over here on my right lower back, and I have been in great pain for the last 7 months, because of the topical product that I use. So I just want to say it worked for me, and I was on gabapentin before, and that was a horrible drug. It shouldn't be given to people, I believe, and I know it's used for nerve and all that, but it did not do anything for me. As a matter of fact, it made me feel really weird. And then somebody using the topical cream, it really has worked for me.
I love that. And the good thing is, right, the topical cream is truly topical. You don't get that mental effect. So if you have an elderly person who's uncomfortable, just a lotion will relieve that inflammation without making them feel, you know, goofy in any way.
Oh, that's all I was gonna ask you. That's what when you use the products, do you get high? That's the one thing that I was worried about, if you're taking the products orally, your pills as well as your tinctures, your oils, will make people high.
It really depends on the effect you're going for, right? We do have lower tier options. If you are somebody who's very uncomfortable with any kind of psychoactive effect, something like the topical lotion is a great option for joint pain, things of that nature. There's no psychoactive effect whatsoever. Or you can start again with just our one-to-one basis, which is going to be CBD, THC. You're not really getting any mental effect from that, and it's starting as low as 5 milligrams, y'all, which is very, very minute in the grand scheme of things. But if you're struggling with like real, I mean, run into people, you're stage 4 cancer, the reality. So you're probably going to need more than 5 milligrams. That's essentially like taking a baby aspirin for your foot that's cut off. And you will have some type of mental psychoactive effect. The reality is, right, that any heavy medication is going to do that to you in some aspect. So like Dr. Abraham was saying, the reality is you probably will go to sleep and get hungry, which is just ultimately going to help you recover faster.
And, surprise, one more.
Well, I promise this will really be the last one. So a number of years ago in Georgia, we passed what was called a rights trial. And this was the legislation that said if your health condition got to a point where you were truly diagnosed with this in and of life, that even drugs that had not been FDA approved, even drugs that had not been through the clinical trials process, that if you wanted to try them to remedy your condition, you could under those very limited and specific conditions. My question is, has there been an attempt policy-wise in many of the states that you may have worked in, or Dr. Abraham, some of the, in the Georgia community that you have worked in, where we have invoked this notion? And I am reminded, and I promise not to get on my soapbox about this, but I mean, you can walk into a store and buy Adderall, which is like one chemical ingredient of meth. You know, we've got prisons full of folks with meth and other folks who will go to CVS and get meth. And yet with this cannabis, when folks do get to end of life, as you mentioned earlier, you know, we have laws that kind of guide and cover this, and my question is there a conversation happening right now about ensuring that cannabis is eligible, so to speak, just as we got sickle cell added to the cannabis approved condition list? Can this also be added to the right to try list? And I don't know that, I remember that legislation, but it was before we were having this conversation with the civil community. And I think emerging these two things could be helpful. And I'm interested in your thoughts from other states and your thoughts from your state.
So I would say the current legislation that is up on the table is not considering that at all. And that is effectively what the point people are getting pushed to. So I definitely see a world in which those two merge. I think a lot of people inadvertently take that route because it is their last try. They are not super worried about the consequences because the other consequences, they're gonna die, right, is the truth. So I totally see a reality in which that's happening. The current legislation that is up on the ballot, the reality is our program is so conservative, y'all. We can't even sell the flower we're growing. So it's, I think, in baby steps essentially, right? We've been moving in baby steps for like the last decade, but the next baby step would be, let's call the program what it is. And I think doing small steps such as that, like let's put it on an exclusion list essentially, is gonna be giving people more security in at least making an attempt to do this. A lot of other states, what they'll do is what I mentioned earlier. You're the doctor. If your doctor is telling you, hey, you are able to take this, that should essentially open up your options instead of your doctor saying, okay, you qualify under end-stage MS, end-stage, whether you're stage 1, stage 2, stage 3, you're still struggling with pain. So I think getting the doctors more authority over the program is gonna go hand in hand with just that.
Thank you, Gabby. I guess for me, I would say, the conversation is not really happening in terms of that aspect. But I think in Georgia, in state, what I've been witnessing is a challenge of me educating people. There is a difference to how, as Gabby had said, how you take cannabis, and whether it's in a capsule form, in vaping or whatsoever. But I think a lot of individuals I've spoken to, sometimes they think, well, you know, I know this guy, he could get this and me and stuff like that. Well, I don't know this guy. This guy doesn't mean anything because you really technically don't know where this guy is getting his stuff from. And there's a lot of stuff out there that's under the name cannabis, but already synthetic stuff that's really bad for you. So I think that's the challenge people really need to address. And I speak to individuals about that because I'm not saying go out any street corner, meet up with a guy and just buy, I don't know, $10, $15, whatever they call it. You know, it's not really healing. So I think that's a challenge where we have to start the importance of the right education and for people to know there's places where you really need to be getting medicinal stuff, not stuff just to be hanging out.
Thank you, guys. Thank you so much. I think everyone was really interested in that topic, right? It's definitely a controversial topic to just see how we can, I think that our hearts just best see what we can do for chronic pain for anybody, whether you're a warrior or not. Moving on, our next speaker this morning is Dr. Bea Lasky. Dr. Lasky is a board-certified physician in blood banking and transfusion medicine. She is the Executive Medical Director of Donor Services and the Divisional Chief Medical Officer in the Southeast for the American Red Cross. She leads the agency's Homovigilance programs, which monitors and evaluates adverse reaction from blood donation and transfusions to improve safety for both donors and patients. Additionally, Dr. Lasky serves as one of the medical advisors for the American Red Cross Sickle Cell Initiative and has spoken many times locally and nationally on sickle cell disease and the need for diverse donors. Please help me welcome Dr. Lasky.
Thank you so much for having me here. What a fantastic event. Just looking around, this is just really amazing to see all of these incredible thought leaders coming together to talk about this. This is such an important topic. I'm just going to spend some time talking a little bit about, so with the American Red Cross, we have our humanitarian services side and our blood services side, our biomedical services. So I work with biomedical services. And we collect blood, and that's what we do. But so, there's a lot more to the story in terms of how the American Red Cross, or just blood centers really in general, can support patients with sickle cell disease from a direct patient care perspective, as well as just working with the larger community and government officials to raise awareness, educate, and so forth, right? What we're doing here today. So sickle cell disease is a genetic disease. It is, we have 3 billion base pairs of DNA information that creates who you are. And one piece of information is altered. And that's really kind of remarkable that you can have
one alteration that creates such a devastating disease. Your hemoglobin is a molecule inside your red blood cells that carries oxygen. So you all know you need oxygen, right? If you hold your breath, you'll find out pretty quickly that how badly you need it. The reason for that is that every tissue, every cell, every organ in the body depends on oxygen to function, and that's happening throughout your life. So in sickle cell disease, there's one point mutation in your DNA that alters the shape of your hemoglobin, and it causes it to your red cells to be misshapen into the sickle shape. So that's where the term sickle cell disease comes from. And so really that does two things. Number one, the red cells break very easily, so you have impaired oxygen delivery to your tissues and organs, and that's really what starts to drive some of this pain. And the second thing is because they're sickle shaped, they lose their flexibility and they can't pass through the vessels properly. And you get basically what's happening is a logjam in your vessels. And so it's essentially like a stroke, right? If you think about, usually it's older individuals who have a stroke because their arteries are blocked. And this is essentially the same thing except for a different reason. It's not atherosclerotic plaque, but instead it's the red cells that are causing the blockage. So you're cutting out blood flow completely. And so what's happening? That's going to impact your brain. In fact, sickle cell disease is one of the leading causes of stroke in children. We recently had a child of 7 who had a stroke. Right? We think about something that happens, and it's never good when it happens, but certainly it's extraordinarily devastating when it's happening to a 7-year-old. It can impact the heart. It can lead to heart failure, infections in the lung, kidney damage, reproductive damage, joint damage. In fact, sickle cell disease is one of the leading causes of joint replacements in children. And usually physicians will want to wait until about 18, or at least when the growth has pretty much stopped. Imagine having, so this is impairing just their ability to walk. Sometimes they become wheelchair bound because it's essentially just cutting off blood flow. It's the joints are dying. And then something that we've talked about already a little bit today is the pain. Everywhere you're in your body that's not getting the blood flow, it's going to start having severe pain. And this is really one of the most common presenting features of sickle cell disease. And when we refer to crisis, it's often the pain that is very hard to treat. And so really, it's such an important topic, what we just heard from the panel today, about how to treat the pain, how to manage that pain. And because traditional opioids they don't always work, and there are challenges with addiction and other things, which I'll talk about a little bit later. But anyway, so the problem is in the red cells, right? The problem is in the blood. So two things, really kind of two different scenarios where blood transfusion comes in is if someone just has a very low, the cells are breaking too much. So just kind of if you don't know your hemoglobin level, normal is probably somewhere healthy is between 13 and 16, 17 or so. We have individuals with sickle cell disease who can present with hemoglobin of 2. So you can imagine, right? The body has an amazing capacity to accommodate, but at 2, you don't have a whole lot left in the tank. And that can fail because now you're compromising all of the organs in your body. And so in those cases, we need to just, fill the tank a little bit and add to that what we call a simple transfusion. Just needle in the arm, blood in the back goes into the body. The other type, and this is for different reasons, either if there's something called acute chest syndrome, where you've got the clotting that's happening in the lungs, and first, you need your lungs to breathe, right? You need that oxygenation. And so that can be also just cause a lot of problems, health problems for the individual. So we can do what's called an exchange, where we hook up the patient to an instrument, it's called apheresis instrument, where we're drawing out the unhealthy cells and we're replacing it with healthy donor blood. And that can require maybe 6 to 10 units, where we can replace about 70% of the blood. And that can be used in an acute setting for like an acute chest syndrome, or for individuals who have been identified as being high risk for things like stroke will actually do preventive exchanges. So they'll be on what's called an exchange protocol, and once a month they go to the hospital and they have their blood, it's like an oil change, where you take out the bad stuff, put in the new stuff once a month, and that could take about 6 to 10 minutes every month. So one of the challenges with sickle cell patients in particular, because many of them are transfusion dependent for their entire lives, that means every month they're being exposed to blood. So just a little bit of a background on the challenges of providing, appropriately matched blood. You have lots of science of it here, I won't make it too complicated. And so everyone has these structures on their red blood cells, actually on all your cells, that are called antigens, and they perform functions and they do their things. And so, but they come in different forms. And so you are probably familiar with the blood types of A, B, and O, you're A positive, O negative, and so forth. There's actually dozens of antigens, and they're usually, we don't really worry about most of them. Some of them have very boring names like C, E, and K, and some of them are named after the people who discovered them, or the patients like Duffy and Kell and Kidd and so forth. And so, why is this important? Well, you go down the line and you'll say you have the big C versus you have the little c. You have the little e and you have the big E. You have the little k and you have the big K. And you have Duffy A and you have Duffy B. And right, so you can see that there's different concepts. Everyone's got their own little combination lock. And so the way your immune system works is that every time you see something that's not you, like the purpose of your immune system is to try to see a bacteria, a virus, some sort of pathogen that's not you, that's its job is to say, that's not me, I need to remove you for destruction, right? You gotta go. And so that's normally a good thing. The problem with blood transfusions is that the more blood that you see that has these, what we call minor antigens, that are not you, you start to form antibodies against them. And that's really where it becomes very problematic for patients with sickle cell disease, really for two reasons, is because they have to be exposed to so much blood, and there's just so many different variations that they start to form antibodies. The second thing is patients with sickle cell disease actually have kind of a revved up immune system such that they are more likely to form antibodies. So they have their patients who have maybe like 9 antibodies. That becomes so extraordinarily difficult to find matches for. And so that's really where we get into, our role in identifying appropriate blood. And where, if you're in a trauma, you're gonna get the O positive probably, or if you're one of the young women, maybe you'll get O negative. And that's as far as we'll worry about the matching. And we'll have 20 units right off the shelf and we can give it to you, no problem. For an individual with sickle cell, when we have to start matching for 3, 4, 5, 9, it's like every time you're sometimes slicing your donor population in half, in a quarter, and right until we have one patient for whom we have 9 donors in the whole country that are matched for her. And so that becomes extraordinarily difficult. Now, what if we can't find that correctly matched blood? A number of things happen. You have a patient who's sitting in the hospital in crisis, and there's just going to be delays. If you're in severe pain, 24 hours is the longest 24 hours of your life, because I actually have one patient that we work with frequently, and it was actually the one with 9 antibodies, and she called me from the hospital. She's just sobbing. I had so much pain. And there was talk about some of the issues we had with getting her blood to her. But during COVID, it was devastating because the blood supply tanked. And so, you either have patients who are just waiting for blood, or you have to, like if they're on an exchange protocol, they're supposed to be getting 8 units of blood, maybe they can get them 6 units of blood, and you have to modify what we're giving them, so we're giving them less optimal care. Or we have to start making compromises with, she's got 9 antibodies, but one of them is not showing right now, so maybe we can drop that requirement. Always knowing that there's a risk of an interaction that, it's better than not giving anything, right? If you've got a hemoglobin of 2, you really have to decide at that moment, are we going to just let the person sit there at 2 in horrible pain and organ damage and, possibly death, versus giving them blood that might cause a reaction. However, there's another level of complication for these patients, because if you do give them the wrong blood and there is an antibody antigen interaction, it can cause what's called hyperhemolysis. So you've got the breaking of the red cells that you just transfused, so kind of undoing what you just are trying to treat them with. And then what happens is that the patient's own red cells, it's like a bystander effect, they also start to die or break. And so then now you end up lower than where you started. So if you started at 2, you really need to transfuse them, but it looks like they're in hyperhemolysis, they can end up at less than 2. So the more blood you give, the lower they're getting. There's no getting out of that, right? That can be fatal. So that's a really difficult balance in terms of how do you transfuse if you don't have the right blood, right? That's something that we deal with very often in sickle cell disease. And so, and I'll talk a little bit more about how we work with hospitals to manage this. But in terms of the community impact, you've probably heard a little bit about this already, but about 1 in 365 African American and Black individuals in the United States has sickle cell disease, about 100,000 in the United States. But that's something that's a little bit hard to really identify, and that's something that I think part of, community efforts are is how to properly track and identify donors, to know our patients, to know where the service, where the service providers are needed most. But it impacts childhood, it impacts their ability to have a normal education. If they have to be in the hospital, 100 times during their elementary through high school years, what does that mean for how much school that they're missing? Maybe they can't participate in sports or dance or whatever else. We hear kids after they've been transfused, like, oh my gosh, I feel like I come back to life again, right? The things that we really take for granted every day, or just being able to play with your friends, go hiking, go whatever you do, right? Whatever your activities are, play basketball. And then it's on into adulthood, again, getting an education, getting a job. If you have to take off 2-3 days every month to get your red cell exchange, does your employer understand that? Are they willing to give you those days off? Are they seeing the patient as a problem? Right, this person just has to take some health problem and they're just taking work off all the time. That can be a challenge for someone who doesn't really understand what the disease entails and why this is so necessary. Creating a family, right? Pregnancy can be very challenging for patients with sickle cell disease. And then, of course, the average life expectancy, and that's something that's almost so hard to say, is the average life expectancy today is 52 years old, which is extraordinarily young. It's about up 6 years, 5-6 years from when I was going through training. So we're making some small improvements, which is great, but 52 is so young, right? And so that's, and then often they're younger, right? Sometimes they succumb to disease in their 20s or earlier than that. So that it's devastating. In terms of what we're doing, what is the American Red Cross doing? Number one, we're looking for donors. We have to recruit the right donors. And so like I was saying, we were talking about having to find not just ADO, but the right combination model for these particular patients. And so we're doing a lot of testing, and that's what one of our, in our laboratories we have over in Douglasville, we have a manufacturing facility. In fact, the organizers, if you'd all ever be interested in organizing a tour at the blood center, we'd be happy to do that. It's quite fascinating. If you're not Swedish, not blood. There's a lot of blood there. But so we have our manufacturing facility that's collecting the blood and processing it so that we can distribute it, and then there's a testing facility. And so we're testing our donors to make sure that we can identify what is the right combination. And part of this is so, and why we're talking about the need for diversity in donors. And I just want to be very clear, because sometimes this part of the conversation gets misunderstood. We are not, and there is no scientific basis for racially matched blood. But what we are saying is that because the red cells have a genetic basis, if someone has a similar genetic background, they're more likely to be a match. Right? So individuals who have sickle cell disease most predominantly are of African descent.
And so there's a certain, your combination lock is gonna look more similar to people who are of similar ethnic background to you. So African American donors, African descent, are more likely to find a match. So, but a match is a match, right? Whether you're black, white, Asian, Latino, whatever, if it's a match, it's a match. So it's not that we're racially matching, and I want to really pause on that for a minute, because when we hear that, it's very concerning, because those words can be problematic and dangerous. So just want to be very clear that we are not racially matching. We are looking for matches in blood, and it's because of that combination lock, and we can be, in fact, half of our blood for patients with sickle cell is coming from non-Black individuals. So it's, just want to be clear on that. However, why are African American or Black donors important is because we can find a match of 1 to 3 individuals, Black or African American or African descent, are a match for patients with sickle cell disease. Where when you look at other ethnicities, it may be 1 in 10 or 1 in 20. And so when you're trying to screen for the blood, you might have to, if you're screening for 20 units to find the one match versus screening for 3 units to find the match. So that's really the value, is that there's just it's a rich supply from donors who have diverse backgrounds. And that really goes for any disease. The more diverse donors we have, the more we can support diverse patients. So we talked about, just our efforts in collecting from the right donors. We also have what's called, there's kind of the standard whole blood process, needle and on, blood and bag, right, whole blood. We also have what's called an apheresis collection, and that's similar to the patients that have to have the apheresis, where we're recycling their blood. Donors can also be put on this machine, and we just collect 2 units of red cells versus 1, and then we give them their plasma and their platelets and everything else back. So we're enriching the donation. Every time we're collecting 2 units instead of 1, and that really helps to support the inventory as well. So we're doing testing. We also work with the American Rare Donor Program, who organizes essentially a national database of our donors, such that when we have a patient with a particular combination lock need, that we partner with the American Rare Donor Program that has access to not only all of the Red Crosses in the country, all of their facilities, but non-Red Cross blood center partners, which means sometimes we're getting a unit from Hawaii or Michigan or wherever. We also put into that, so we are sending blood to other states. And that really opens up opportunities for patients. And sometimes we are having to collect blood from here and here and here and here to just have a full set of 7 units for one patient for their exchange. One of the challenges with that is that because now there's actually other reasons, and I won't get into why, that sickle cell patients have their blood needs that have to do with variants. So I was talking about like C and E. So most people have either what we call a big C or a little b, big E or a little e, or both. Some people have neither. They have what's called a variant. And so now you can actually make antibodies to both big E and little e, which means almost nobody is a match for you. And you have to find someone who has the same variant, which means we have to actually do molecular or genetic testing to find that match. And so the ARDP, American Rare Donor Program, usually wants active orders for transfusion, meaning no one should be hoarding the blood, right? Because someone else might need it today. So we have to be really careful when someone has unique blood needs, how much we can just save for that person. Now they do allow us a little bit of flexibility depending on the circumstance, and I'll share a story in a little bit about that. But so we're also doing patient testing, where the hospital sends us the patient specimen, and these are really some of the most complex blood banking workups that exist for patients with sickle cell disease, because you have to figure out, it's like a 3-dimensional Sudoku.
problem is trying to figure out what is the features of the antibodies and how to find the right match. So we're doing that kind of testing, and then we issue products to the hospital. And then we also help educate them to make sure that they're aware of if we have had to make some compromise on, instead of the 9 antigen matches, we have to send 8. What are you looking for? What are you monitoring for? And how to manage that patient? And how do you maybe pre-medicate them with steroids to suppress their immune response to make it less likely for them to have a reaction? There's also things that we can do, which is, we've heard earlier from recommendations from the American Society of Hematology that suggests or recommends, I should say, prophylactic matching. So in order to prevent antibodies from forming in the first place, you just identify what that patient's combination log is before they start to develop the antibodies, and you match it ahead of time. And that's really kind of optimal to prevent, because once someone starts forming antibodies, it kind of starts to snowball. And so all of the big academic centers like Emory and so forth, they are at the cutting edge. They're going to be very familiar with the most current guidelines. That's not always the case with community hospitals and smaller hospitals. And so we have, the American Red Cross has 35 medical directors that provide 24/7, 365 consultation for hospitals who might need guidance on how to manage these patients from a transfusion perspective. In terms of how we continue the conversation in the community, we started out, so we have been, particularly in Georgia, because we have such a large sickle cell population here, we've always been providing blood for patients with sickle cell disease. But the organization started a formally organized sickle cell initiative back in 2021. And we started out by partnering with Black Communications Group to really understand I'm sure you probably are all educated on things related to sickle cell patients and the community that it impacts. And there have been some really horrible, horrendous, just criminal things that have been done to the African American community in the name of medicine and science. And there are trust issues. We want to engage with a community that has been historically abused by the system. How do you overcome that? And that's something that we wanted to do very carefully. We didn't want to just come in and say, okay, we're checking our diversity box, right? That this is something that the care of patients with sickle cell disease is something that's incredibly important to our mission of alleviating human suffering. And how do we do that in a way that really develops the right relationships with the community in a very meaningful way, and that we can really do it in a way that's sensitive to the history and sensitive to humans, really, right? That we're not just talking about disease, but we're talking about humans. So, and how do we develop the right, just the right approach? We work with faith-based organizations. We work with historically Black colleges and universities to raise awareness, to develop partners in the community, to, we train the trainer, right? Go out to form your own university clubs and to raise awareness for this. We work with colleges, and we also work with high schools to develop. We have some scholarship programs, and for individuals who get involved with our sickle cell initiative, and then we also have leadership programs for individuals that just help them become leaders in their community, so that they know how to run an event like this, how to talk to your government partners, how to become advocates. So we think that, really helping to grow the next generation of leaders in this space is critically important. We also have public health initiatives. So we offer health testing for things that are very impactful to the Black and African American community, so that we can be giving something back. As we're asking individuals to come and give blood to support patients with sickle cell disease, we also want to offer something back. So that can be in the form of sickle trait testing. So we've offered, I think we're probably at about 300,000 tests we've offered, at no charge to blood donors to identify if they are trait positive. And it does help some, it's not the same as sickle cell disease, because you have one copy instead of two. So you can be symptomatic in certain circumstances, but if you have two parents that have sickle trait, that means you have a 25% chance of having a child with sickle cell disease. So this can be important for managing your own health and your family's health. We also have a hypertension initiative where we're monitoring blood pressures at the time of donation. It's something that we do anyway. So we make that available in health charts, as well as sending notifications when it looks like someone is in the hypertensive range. And this is actually very impactful to the African American community who suffers from hypertension at a very high rate. And then that can have an impact on sight, on kidney function, amputations. It's considered the silent killer. And so it's something that can actually improve the health of the community. And then also A1C testing, which is related to diabetes. African Americans and Latinos have the highest rates of diabetes in this country. And so identifying elevated A1C levels can get individuals into care earlier to start managing some of the complications and to prevent the organ damage. We also, we identify opportunities, we take opportunities and create them to work with healthcare partners. So, we've been working with a health insurance company in terms of finding, this isn't for individuals in particular, just so there's like no inquiry into individuals and their health data, but we can look at, say, a hospital has the diagnostic codes of sickle cell disease or acute chest syndrome, right? Things, the constellation of diagnoses that would suggest a certain type of care needs to be delivered, like a red cell exchange. And then if we see that there is not a proportionate number of red cell exchanges being provided, that lets us know there's something there that's not happening that should be. Whether that's education from the physicians, and I have to say, it's caring for sickle cell patients is a subspecialty in and of itself. Not every physician is just right out of their training going to be able to identify the symptoms and to be able to know what the correct management is, whether that's the simple transfusion exchange protocol, what type of pain management, and so forth. So there's a lot of education that's needed just to be able to identify the patient correctly and then to provide the right kind of care. And of course, as we discussed, if they're not getting the right kind of care, they're going to be developing antibodies and have transfusion reactions. So education is really important. Identifying care deserts. We know that there's a huge care deserts, particularly in remote or rural areas. We have Grady and some very large centers that provide fantastic care, but people are often either having to drive many hours, or they're having to actually just move to the Atlanta area to get the proper care. So how do we work with our care providers to identify where the care gaps are? How do we even start figuring that out, right? Because if they're moving to Atlanta, now we don't have their native address of where do we go to find them. There are challenges with reimbursement issues in terms of where you can actually do a red cell exchange and in what environment, what kind of medical monitoring do you need. And then there's issues with transitioning children to adulthood. Generally pediatric centers have much stronger care, and of course you've got the parents who are bringing the children. Once that person turns, from 17 days and 17 years, 364 days to 18, they're now considered an adult. And the level of care can be different, as well as the patient having to become their own advocate. And so there's a lot of challenges there that we could be doing better with that kind of transition type of care. We also talk about a nationwide antibody registry. And so just to identify kind the scenario of what might happen for a patient is that if you have a lack of adequate education for the care provider, they're not identifying the right symptoms, there is maybe a lack of delivery of proper care, if they're not managing their sickle cell disease correctly, or they might be even viewing the patient as a drug seeker. And this is a huge problem. We talked about this a little bit earlier with the opioid crisis, is that, if opioids are the leading sort of solution or care for the pain, and that person was saying, I'm in pain, I need drugs, but I need medications. This is a real medical need, and it can sometimes be seen as drug-seeking behavior. Then that leads to what we call hospital hopping, where the patient is going from hospital to hospital to hospital to look for someone who's actually going to be able to provide them the proper care and pain management. What that does is, if it's within the same system, that might be okay, but if they're going from Wellstar to Piedmont to Emory to right, those they're not communicating necessarily. So now there's lack of sharing of records, and this person might have 9 antibodies, and the next hospital doesn't know about it, and they're gonna transfuse them, and that can have devastating impacts. So fortunately for the Red Cross, it doesn't matter where that patient is being seen, because we have records for them that just span their entire history. So really there's a lot of interest and work being done in a national antibody registry, where all hospitals who decide to participate would have access to a limited amount of this patient's history, specifically as it relates to transfusion. What antibodies do they have, what combination lock, what is their phenotype, and what kind of special blood needs they have, so that no matter where they go, they're getting the right care. And of course, this is, this just creates, it requires a lot of data input, it requires a lot of just support to create a database like this, while making it still HIPAA protected. Who's going to be putting information into it, who validates the information to make sure that it's correct, who's drawing out of it, and is it impacting insurance and so forth. So there's just a lot of, it sounds like that's wonderful on the surface, but there's really a lot of issues to solve. So we do have, I know we've got partners at Emory and some of the large sickle cell centers that are helping to develop this. And it's something that we work with our government officials as well to recognize the value of this for caring for this particular patient population. And then there's also reimbursement issues when someone is maybe their main care area is in certain states. What if they're in a different state, and how do we get the blood to them? Is that going to be reimbursed? Again, are they waiting? We've had a young woman with the 9 antibodies who we've got blood in for her in Georgia, Alabama, Tennessee. She was in Nebraska, and we couldn't get the blood to her because of insurance barriers. And she was sitting in the hospital again, waiting for blood. And so there's work to be done on the insurance side. And then finally, we look for educational opportunities. How do we constantly work with the public, raising awareness with the community, with our hospitals? We have a platform that reaches all about 1,800 of our hospitals, where we're educating them on meeting, the ACT guidelines of optimal transfusion care. We're partnering with the American Blood Donor Program. We also partner with hospitals who are doing clinical trials like gene editing. We had just one patient recently who went through the gene editing process, which edits the genes so that they're not having elevated levels of this sickle hemoglobin. And what we needed actually was to reserve 16 units of rare blood, because once you go through the process, there's a point where you can't stop, you can't pause. So we needed to have that ready ahead of time. And because she had rare blood, we would save 2 units, and then she would need to use one. And then she would reserve 3 more, and then she needs to use another one. So it took us about 2 years to reserve enough blood for her to go through this gene editing program trial. She has, she's engrafted, and so far it's looking successful. But partnering with those to increase the access to these clinical trials is is really important. Because, so funding, when it comes to funding, because they're extraordinarily expensive. So I think Dr. G, you talked about that earlier, in terms of, making these clinical trials more accessible is also very important. And so with that, I'm happy to take questions. I know we're running a little bit long.
Thank you, Dr. Gillespie. I think I'm always amazed to be reminded of the crucial role that blood centers typically play in any patient's care, whether they have sickle cell or some kind of a face disorder. So thank you for reminding us that it's not just physicians in a hospital, but you all play a crucial role in community hospitals as well. If someone is interested in being a donor, what should they consider? How long does it take? Is there a cost to it? Is there insurance involved? What can you do to kind of activate folks who are right now to think about that process and support sickle cell warriors and their families?
So to become a blood donor, very easy. You can just go to redcrossblood.org and look up appointments, so you can put in your zip code and it'll show you where there's a nearby either a blood drive or a donor center. If you're donating a whole blood, well, so the registration process is the same no matter what. There is a questionnaire that will ask you some pretty personal questions about your medical history, medications, some social behaviors, and it's just to, for the safety of the donor as well as for the safety of the patient. But that part is probably about 10 minutes. We'll take your blood pressure, temperature, check your hemoglobin to make sure it's high enough that it's safe for you to be donating. And once that's been determined that it's safe for you and it's safe for the donor, if you're doing a whole blood, needle and arm, blood and bag, that takes about 10 minutes. If you're doing a double red, either if you are what we call one of the right types, like an O positive, O negative, A negative, or B negative, and there's reasons behind that why those are useful. Or if you're not one of those right types, but you happen to be the CEK, or one of these sickle cell, we call them the sickle cell fighters, then you might be eligible for a double red as well, and that would probably take more like 45 minutes because you're on the instrument. But it's very easy, and so how often can you do it? If you're a whole blood donor, you can do it every 56 days. If you're doing a double red, it's every 112 days. And usually most people feel fine, we just encourage you to eat iron-rich foods to help boost up your iron. But otherwise, and if you happen to not be eligible, or some people have reactions where they just feel kind of nauseous and it's like, that's not for me. It's like me. I don't feel well when I donate. To say the least, it's actually bad. But so some people it's like, well, I can't do this. Volunteer. Right, we have so many volunteer opportunities. Again, redcross.org, volunteer, and we have sickle cell advocates. We have people who are just helping with either scheduling blood drive, recruiting donors, helping at the actual drives, so you're actually working with the donors, and we have just a spectrum of opportunities. And then particularly if you're affiliated with a church or a school or a business where you can actually help schedule drives, that's amazing because now you go out there, you're not donating just your one person, but you're helping 50 people, 70 people, whatever to donate. So really a lot of opportunities, just boots on the ground opportunities.
Has there been a study where continuing with the sickle cell disease or being RH negative? And also is it good, if there's RH negative to donate?
Yeah, so individuals with sickle cell disease are actually more likely to not be RH negative. So RH is one of those antigens. It's the D antigen. One of these really creatively named antigens. So you're either D positive or D negative. And so that's what you're talking about with the RH negative. So O positive, D negative, and so forth. We're talking about the D antigen. Individuals with sickle cell disease actually don't need the D or RH negative blood. For individuals individuals who are D negative, they usually need that D negative blood, because again, if you're D negative and you see D positive blood, you're going to need an antibody against it. And for anyone there's probably at least a proportion of women here who have had to have RhoGAM injections to prevent the antibody formation. So it's not necessary. And, you know, but if they are Rh negative, we'll find a match, but it's usually the issue is the CE and K negative that we're in need of. And so that's what we're doing in our laboratory, is identifying what the patient is, what the donor is, and how to find the best matches.
Thank you so much for that information. I'm pretty sure that what you provided for us today, a lot of people were unaware of, so we are definitely more educated now. I'm not sure about you guys, but I kind of need to process a lot of this. There was so much information, and so we are going to do our wellness breaks. Please use your passports and visit all of our stations. Please do the raffle to enter in your chance to win service at our wellness sanctuary. We also have merch outside, sweatshirts from the Sickle Cell Foundation. Please support us in that way. And if you have a few seconds, you can take a look at our brand new show on Family Sickle Cell Beyond the Pain, now on YouTube. So please, let's take a break, take a breather, and we'll see you in about 15 minutes, okay? Thank you.
The Sickle Cell Legislative Conference and Policy Review will return in 15 minutes. Please use your passports and visit the different stations.
Ladies and gentlemen, please go and visit the wellness station. We are about to do a very special demonstration. So please, if you can, make your way to the back of the room to the wellness station for a very special sound bowl demonstration.
hands, roll your neck, your shoulders are dropped from your ear. Make sure your tongue is not closed with your tongue. That's how long it's. So now we have about 6 minutes left, so I want to talk to you about sound bowls. Who has done sound bowls? Who knows what they are? Please share. Let's switch places. Come over here. She will. That's exactly right. So your body has 7 areas, all with different motions. And our bodies are made of water. You ever seen a cup of water on the table or somewhere and vibration comes by? You see the water vibrate? That's what happens in your body. So each of these represent different spiritual systems. Which times emotions and each of them. And I'm going to share with you what it represents. What you may be experiencing if there is a blockage in the chakra, and then we will go through a sound bath. If you have any questions, let me know. Okay? That's your root chakra. Root chakra is at the base of your heart. Position base of your heart. Represent your stability and your security. When this is out of balance, you may start to feel scattered energy. Sure. Maybe uncertain about life. You have a blockage in this area. The healing intention of your chakra is I am safe. Your next chakra is your second chakra. Touch right below your belly. That's your lower abdomen. This represents your creative and sexual. So, this is your emotions, right? This is, you have that repressed creativity. Some people may have been like, well, I used to be a writer, I used to paint, I used to love to do these things, and now I'm not. You may have a lot of change in that same chakra. So, when there is a block here, you might start to feel some shame, some guilt. You may have some emotions that you're withholding, struggling with sexual intimacy. That's what this chakra represents. What you're going to say with me now is, I flow with ease and joy. Ready? I flow with ease and joy. So next we have our solar plexus energy. Our solar plexus energy is what represents our self-esteem and our pleasure. This is going to be in your upper abdomen, right above that belly button area. If you have a blockage in this area, you'll notice that you have lower. You may have been securely confident about yourself, but now you're questioning everything before you do it. Notice the imposter syndrome, wondering if you're good enough to do certain things. It's typically represents a blockage, and that's the you'll find yourself being short, with low motivation, not a motivated to that can represent a blockage in your area. Your healing intention for this chakra is, I am confident and strong. I am confident and strong. So next we have my heart chakra. Just feel that heart chakra. This represents love, self-esteem, and good relationship with yourself. You're going to give this little big shout. We always go here. It's technically here, but that's okay. It's all the same thing. You notice that you have these areas of depression, difficulty in relationships, difficulty with yourself, relationship with yourself. You have a block in business, there's confusion, there's lack of clarity, feel like you don't know what to do, but you want to take action, you don't know what action to take, I think we have some work to do. So just hear it out. So say it with me. I trust my intuition. Last but not least, this is your higher purpose. It's gonna be at the top of your head. You have a blockage here, you may exist, that shows maybe you've been doing spiritual practice, very transactional. So I want you to say with me, I connect
So started to organize theoretically, there's lots of right. This is not that science. Right, so you know what I mean? Like, it's different. First five. Actually, again, not exactly. So exactly. And like,
You were back. I bet everybody needed that great chance to, bring it all together, a little wellness, a little rejuvenation, a little networking. That's what this is all about. Standing discussion. So if we can we have everybody come back to their seats, please, as we start the next presenting. Our next speaker presentation is by Tracy Sikora. Tracy is the Vice President of Research and Clinical Programs at the National Organization for Rare Disorders, or NORD. NORD is the nation's leading and the longest-standing nonprofit organization working at the intersection of care, research, policy, and community for all patients and families affected by rare diseases. NORD's network of patient advocacy organizations include more than 350 nonprofit members representing specific rare conditions. NORD's Chief Executive Officer described the Sikora this way. Tracy's emphasis on strategy, her dedication to patient-centered initiatives, and extensive experience with rare disease makes her a standout leader of NORD's medical affairs team. Ms. Sikora started her career as a research specialist at the University of Pennsylvania School of Veterinary Medicine, where she conducted studies in preclinical models of rare genetic disorders and studies involving gene therapy and treatments for rare diseases. She continued her career in multiple roles, including as a clinical research coordinator and associate director at the University of Pennsylvania School of Medicine, Department of Medical Clinical Trials Unit. She's made a significant impact in clinical research, rare diseases, and most importantly, in the patient care space. Let us give a warm welcome to Ms. Tracy Sikora.
Thanks, Alex. Many of you saw me yesterday, but I am really excited to be sitting next to Tracy in the National Organization for Rare Diseases this morning. We got quite a bio from you, Tracy. Anything that you want to add in terms of your background, how you got here, and why this is also important?
Yeah, absolutely. So first of all, thank you so much for having me here and for organizing this event. I've already learned so much today. My background is non-specific. I've worked in many different rare disorders, and so anytime I get to deep dive into one specific one, me. In my role at NORD, I oversee a
Closer to your
thank you. A variety of research and clinical programs, including a data platform for collecting data from lots of different rare disease patients, and working with academic physicians so that we can be sure that that community, we are working with them carefully as well as we represent the patients with rare disease. So at NORD, we represent patients and families from all rare diseases and work to advocate for care, research, and policy.
That's super helpful. We know that oftentimes when it comes to the sickle cell community, that research is underfunded. Given the work that you all have done with other rare diseases, are there any lessons learned that the sickle cell community can kind of take forward and can apply to them and kind of strengthen some of their efforts that they're doing?
Yeah, I think on the research side, we have seen some communities really come together with that research focus and move forward in drug development. Same thing with the advocacy side. But I do have to say, when I think about other groups asking this question, sickle cell comes to mind as a leader in this space. So I think of the sickle cell community as actually the example of it done well. So just so much kudos and appreciation for this community and the incredible work that has already been done. But I also know that there's always opportunities for rare disease communities to learn from each other. So it's really important to continue to reach out and communicate with advocates across the space, because there's always an opportunity to learn some new advocates, some new ways to advocate.
That's a good point. And that we're aware that there's a heavy burden, particularly in the southern states, and the way that the board convenes a lot of those partners nationally. I was wondering if there was any particular opportunity or advice you can give to folks in the room today about regional alignment. Obviously, there's a lot that can be done in Georgia, and the Sickle Cell Foundation of Georgia has done a phenomenal job in leading, but there's still patients who go to Florida, there are patients in Alabama who come to Georgia. So what kind of lessons learned can you give to other states with respect to regional alignment?
Yeah, I want to share a few notes that the policy team shared with me from NORD about the really incredible work that's been done in this region. We know that if we look at the different divisions across the U.S., that the South and the South Atlantic and East South Central divisions of the U.S. are the only ones where every single state has a rare disease advisory committee at the state level. So these hard acts are doing state level advocacy for rare diseases, and that includes Delaware, Florida, Georgia, Maryland, North Carolina, South Carolina, Virginia, West Virginia, Alabama, Kentucky, Mississippi, and Tennessee. So this is really unique. And that's an incredible achievement. It means there's this ready-made network already collaborating. Just last month, we had these groups and then 13 others come together in DC for a meeting and really look for ways to collaborate across the region and across the US. And then we also know that here in this region, almost every single southern state except South Carolina participates in the Interstate Medical Licensure Compact, which means that really streamlining that physical licensing across states. So we already know that in this region, especially, there's a lot of collaboration happening, a really great opportunity, almost uniquely here in the US, for some regional collaboration.
That's wonderful. We've heard a few times today and yesterday about data. I know that Curly is a huge information source for you and the work that you do. It's a huge information source for clinicians and even some of our blood center partners, as was mentioned today. What role can data sharing play in strengthening some of the cross-state access to care challenges that Georgia and other states in the Southeast region are encountering?
Yeah, data is incredibly important, and one of my roles at NORD is really trying to gather and collect really robust data. I mean, data is helpful when you have a large amount of it, and when you have a rare disease, that getting to that large level of data is particularly hard. So data sharing means that you can get more opportunities to use data effectively. In the cases that you're talking about, we can use data to determine where is their need, where are the concentrations of patients who are not receiving the care that they need to receive. And that can help you allocate resources more appropriately. This is just one example. You can imagine how the better, higher quality, more data that you collect, the more that you can do with it to effectively serve patients.
That's super helpful. And the concept of registries is coming too. Whether it's registries done by survey, which is currently funded by the CDC, the antibody registries, which Dr. Lasky mentioned earlier. Do you see any gaps in information collection or particular data elements that you think would be helpful for some of the research that either NORD leads or some of NORD's research partners are leading?
Yeah, absolutely. There's always going to be gaps here. I think that when we are launching registries at NORD or supporting organizations who are launching registries, it's really important to us that the patient communities own that data themselves. So they're the ones who are shepherding who gets access to that data and how it's used. I also think it's really important that we're collecting information directly from patients, so patient-reported outcomes. And then we're developing questions so that we're actually getting the information that's important to patients and it's being collected in a way that is important and easy for them to share. But there's technology now that's evolving to maybe allow us to do data collection even better. So now we're able to collect information directly from electronic medical records. This is a great opportunity, but we do need to make sure it's done in a safe way, in a way that protects patient privacy, and also that it's accurate, because medical records, they were first designed to help with billing, not necessarily to do data collection on a really robust way. So there's a lot of opportunities to improve this, but I do think that it will really aid in how we're potential for care.
Yeah, I imagine there's probably opportunities, particularly in sickle cell, we're dealing with issues like stigma, to enhance patient-reported outcomes as well, and incorporating that into some of our research initiatives. Data sometimes being a challenge, but you mentioned really focusing on clinical outcomes, and we know that there are access challenges to care. One of the ways that states are trying to remedy access challenges is through the medical licensure compacts, just expediting the way in which a physician can be licensed and provide services across the state. That's a way to alleviate that administrative burden. Another way, and I mentioned this briefly yesterday, is the Accelerating Kids Access to Care Act, which was specifically made Medicaid-enrolled physicians eligible to not just practice, but to bill for services, particularly specialty services, in states where they may not live or have a practice, but they know that there's a need. Can you talk a little bit about how this policy approach introduced and again was supposed to be passed in December of last year, but still pending in Congress? Can you talk about what it would do for the rare disease community if it were passed, particularly sickle cell?
Yeah, so those who may not be aware of how this works with Medicaid may be surprised by this, but because Medicaid is run by states, if you cross state lines and want to see a specialist who may be in another state, in rare diseases, this is very common because often there's a small number of physicians or care providers who are specially trained and knowledgeable in a specific rare disease. So often you have to travel to get that specialized, high-quality care. Unfortunately, sometimes it's a very difficult and complex process for that provider in another state to be accepted by your home state's Medicaid program. So often it requires a very lengthy and difficult process. I've even heard that there are some states that require questions that don't even seem relevant to medical care, like they require the social security numbers and signatures of everybody on the hospital's board, which doesn't really make any sense. Sometimes it takes 6 months to even get through the process, and then they require that you do it every 6 months. And so this process could be much more streamlined. And so the Accelerated Kids Access to Care Act would be a single opt-in federal program. Would allow you, a physician or a care provider, to enroll in multiple states at once, and then to stay enrolled, so they don't need to reapply every 6 months. And this would be eligible, MDs or DOs and care providers who treat patients under the age of 18 would be eligible to enroll in this program. And I will say that at NORD, it's one of our top policy priorities. I think, as you mentioned, it was, has great bipartisan support, has 8 co-sponsors in the House, and did pass the House, and then was not to make it in that last minute, made its way into HR 1, didn't quite make it at the last minute, and so, at this point, we, of course, are urging everybody here to speak with their representatives, call their representatives, and really urge them to act on this bill.
We've heard from many partners over the past couple of days. Just recently, we just heard from the blood centers about the crucial role that they play in enabling and supporting some of the care teams who are interacting with patients in the the hospitals, both at the community level and some of our large research and university academic centers as well. But there's still access burdens. Patients have to travel many hours to see healthcare providers. Many of them have to go across state lines. You talked about the advantages that this particular bill would afford healthcare providers, especially those who are specialists, whether it be hematologists or those who are specializing in cell and gene therapies. What can the bill do for patients, specifically the sickle cell warriors and their families who are covered under Medicaid right now?
Yeah, so if it's not clear, it means that you can travel to that specialist, right? So if someone in your home state doesn't have that level of knowledge, you may be receiving care that's not the highest quality care that's out there. So being able to travel to another state can be getting access to that care. Travel is a burden though, so maybe it would allow in some cases shorter distance to travel. If, for example, the only way you can get access is to travel 3 states away, and now this act would allow you to travel to the next state that highest quality care is.
It's like expanding the provider network.
Yeah, absolutely.
Which is a great list to look for that. What advice would you give to state level advocates who want to make sure that their voices are heard in sickle cell, but again, in the broader rare disease space too?
Yeah, I mean, the state level policy work is so important. I think NORD, we want to make sure that these policy advocates know about the rare disease advisory committees if there is one in their state. We also want to make sure that they don't discount themselves because they're advocating at the state level. They can still have a huge effect nationally. And I think a theme that I often talk about is collaboration and community. So things like NORD bringing together state policy advocates across multiple states together. There's a lot you can do to learn from each other to make sure that we're all advocating for things that are our individual states, but we find opportunities to work together on collective action.
I have a question here for you. If there was anything that you could leave with the audience today in terms of any tangible next steps, what would that be?
Yeah, besides going to Congress and to your state policymakers to advocate for legislation that helps our communities. I really think, again, I'll talk about community and collaboration. I've seen this over and over again, where we see success when we have collective action. We know that we're not going to agree with everybody else on everything, but finding common ground to work together is incredibly important. So I think if there's one thing you can even do that's very actionable is keep having events like this. And so bringing together people from different backgrounds with a shared goal is really going to accelerate progress forward.
Well, I'm glad that you're here as an ally to the Sickle Cell Foundation of Georgia, taking that message back to DC. I appreciate you all convening us. Open to any questions if you have them. Answered all the questions. Well, thank you so much for your time this morning.
Thank you, Tracy and Latoya. We really appreciate your help. So we're going to move on to our next panel discussion on care coordination and mental health policies and legislation. Across the country, communities are grappling with the challenge of connecting people with the care they need, when and where they need it. Too often, individuals, including sickle cell warriors living with mental health conditions, must navigate a maze of disconnected systems, from healthcare to housing to social services. Today's discussion brings together leaders in healthcare and advocacy who are working to change that. Together, we'll take a look on how legislation and community partnerships can strengthen care coordination and promote better mental health outcomes for all. Please join me in welcoming our panelists as we explore how thoughtful policy can transform coordination of care and the lives of those who deserve it. Will Dana Hill, Clayton Andrews, and Dr. Otis Powell please come to the stage? Please help me welcome them. Clayton Andrews is a licensed professional counselor and a certified professional counseling supervisor. He is also a sickle cell warrior, a husband, and a father of 7. Dr. Powell is a primary care provider specializing in family medicine with more than 40 years of experience in treating patients in Metro Atlanta. He is the medical director of the Sickle Cell Foundation of Georgia. He is affiliated with Wellstar Atlanta Medical Center, and he is an expert in chronic pain, generalized anxiety disorder, fibromyalgia, and type 2 diabetes. Dana Hill is a mental health nurse practitioner with 18 years of diverse nursing experience, dually certified as a psychiatric mental health practitioner and a family nurse practitioner. She works at, yes, the Sickle Cell Foundation of Georgia in our Sickle Cell Sanctuary, Holistic Healing for a Better Tomorrow. Thank you guys for joining us today. First question I have for you guys. When the state legislation passed the Mental Health Parity Act in 2022, it was considered a groundbreaking achievement. It meant for the first time, all health insurance plans had to cover mental health conditions just like physical ones. So patients could no longer be denied medically necessary treatment. Dr. Powell, have you noticed a difference in your practice in the few years since this law took effect? And has it helped more people receive treatment?
Yeah, first of all, I've been doing this for 40 years. And we'll get a haircut yesterday, so you wouldn't see the gray hair in my head. But I think since the act was passed, I do see some big strides in mental health. But for everyone, including sickle cell patients, I want to applaud the Sickle Cell Foundation for taking the lead on dealing with some of the mental health issues. Unfortunately, a lot of patients with sickle cell disease have some difficulty accessing mental health services. So, by the foundation taking that lead and developing a program for mental health is definitely a stride in the right direction. One of the things I've noticed in mental health in reference to sickle cell disease is the mental health practitioners need to be very educated on exactly what sickle cell disease is and how it impacts those with the illness, and be aware of a lot of the mental health issues that come with having a genetic condition that's been with you since birth, and going through the pediatric years and going into transition is extremely stressful for a sickle cell patient. We know the pediatric care is a lot more organized and it works a lot better. So when the kids transition out of pediatric care to adult care, there's a lot of fragmentation and there's a lot of resistance of practitioners wanting to take care of sickle cell patients. both physically and mentally. So all of us have to do everything we can to get practitioners more educated on sickle cell disease, so they can have a lot more understanding and compassion toward taking care of this extreme problem.
Thank you, Dr. Powell. Dana, tell us if you've seen an improvement in your practice in the number of sickle cell warriors who can access treatment as a result from the Mental Health Parity Act.
Since passing of the act, there has been some increase in the patients that we're seeing. Insurance companies are granting them the access to be able to go to therapy, cover their mental health medications. But like Dr. Powell said, that even though the act was passed and we see more patients, there's still access. So I feel what gives me hope is that now we're offering telehealth for the patients, so we're able to continue to see them and have that outreach.
Thank you, Dana. Clayton, how you doing today?
I'm good, thank you.
Good. Chronic pain from sickle cell disease can lead to mental health challenges for warriors. What are some of the biggest challenges you see in trying to coordinate mental health care for sickle cell warriors?
Going back to, for instance, idea of practice we're talking about, Atlanta, Georgia has some of the biggest and best medical facilities in the state. And at the same time, go to any one, you're gonna find something different on the front lines. You might find one that, come on in, we got you, we're gonna get you. But then once you get upstairs, it's delayed care. You might get in and have to wait several hours before getting upstairs for immediate care. And then you might have some that say you want to wait. Other challenges include, I know the physician earlier this morning, that those differences in how we are viewing not only our providers view people living with sickle cell, but those cultural views of people of color, how they view medical systems. You know, again, kind of going back to you going to the hospital for care and providers that are uneducated or unaware might see you as a seeker. I view that word a lot. And then at the same time, that resistance to like mental health care or any care, especially Western care, because of a history of those medical indiscretions. You know, Tuskegee, for instance, right? I was in my 20s, you probably couldn't literally pay me to participate in the study out of that kind of fear. So we have those kind of disparities again, you know, culturally. As a mental health expert myself, I'm the first one to say, you know, as a Black man practicing mental health and psychology, it wasn't too long ago that running away as a slave was considered a mental illness. So there's a hesitancy culturally even when it comes to looking at running. There's to put that together, it creates kind of a pain, depression cycle now. Living with sickle cell, living with the pain. If you're having that, if you're having a worse day, and then that anxiety of wanting to go and experience that care, you're having that anxiety just leading to the pain, and it's kind of just eating off of each other. So those are some of the bigger challenges that I'm observing.
Sure.
Oh, yeah. Oh, okay. If you instructed us to look at her. Yeah, no, as a practitioner, taking care of sickle cell patients for a number of years, I had the opportunity to do it on all levels, at primary care, also did 31 years in emergency medicine. I worked in mental health for 17 years, so I've had a chance to see the whole spectrum of issues. So I think one thing that has to be emphasized is that practitioners need to do more screening for mental illness, a lot more than what we're doing now. I work with PA students and nurse practitioner students, And I sort of tell them that when you go see a patient, you need to, probe into what's going on with them. Oftentimes when patients go to the doctor, even sickle cell patients, they feel that the providers are really not interested that much in their mental illness. But so the providers have to actually probe into that and see what's going on. We know chronic pain causes depression, and sickle cell patients get other mental illness just like anybody else. I think there's a movement in the right direction, but there's a lot more education that's needed, and we need a lot more providers. They're not enough psychiatrists. I've been told about a number of my associates that they call their office to get an appointment in maybe 3, 4, 5 months before they can even see them. So more primary care providers, more psychiatric nurse practitioners, and so forth, are going to have to take a big role in the care of those with mental illness, especially sickle cell patients.
Thank you. So there are a number of bills from 2025 legislative session that we're watching. One House bill is 612, would add the insurance commissioner to the Behavior Health Coordinating Council. It would also require educational materials for consumers and providers on mental health parity and establish a review panel for violators. Dana, in your day-to-day work with the sickle cell warriors, how important is this bill and why do you think it's needed?
This bill is very important. I feel that it gives the parity act teeth. And when I say that, I mean we can institute pen to paper all day long, have policies, but who's actually holding insurance companies accountable? I especially like the education piece of the bill because it's informing patients that they have the right to, when their claims get denied, they can institute a review of what's going on. And it also inform the providers when parity is working. For example, I'll have a patient, I see them says they have a mood disorder, I order medication, and then I get a fax from the insurance company. Patients trial and fail 2 medications before prescribing this medication. So I have to use a cheaper form of the medication that I would like to use before prescribing what I need. So being a provider that sees primary care mental health, I don't remember, ever getting such a letter when I was prescribing for hypertension or prescribing for diabetes. So it's very much still unequal. So the bill, that House bill is very important. It's going to hold everyone accountable.
Thank you. And so I'm listening to all of you, and you all have very similar perspectives, but of course different backgrounds when it comes to mental health. So my next question is for all of you. Are Georgia lawmakers doing enough to tackle the challenges associated with mental health care for sickle cell warriors? And what ideas do you have for improving that kind of care?
Okay, I'm not looking at you. There's always a lot of improvement. Year by year things change. We need to make sure that we are making the policymakers aware of what's going on and keeping them informed and educated, and letting them know the seriousness of the needs of those sickle cell patients and the need for mental health services that are streamlined and are less complicated, and help practitioners not get bogged down in paperwork and so forth, trying to get people proper medications that they need.
Repeat the question one more time.
Okay. Are Georgia lawmakers doing enough to tackle the challenges associated with the mental health care for sickle cell warriors? And what ideas do you have for improving that kind of care?
So I can definitely say, in recent years, they've definitely been In improving that care, and there's so many different facets of that, have finding ways to educate our healthcare providers, again, those frontline, can you hear me now? One method is finding ways to educate, kind of, don't get back on what I was saying earlier, this frontline care, and even in the, I'm sure those that it cares, but that universal, have some kind of universal way to educate our healthcare providers on treating those living with sickle cell, especially that. You have floors dedicated to it. You have programs and everything dedicated, but there's always different receptions again, when it comes to sickle cell. Another method, we're thinking about specifically mental health. I did a year as a first responder clinician with the local sheriff's department in Cherokee County, where I partnered with an officer and we met on crisis calls or people with emergencies and things like that. One of the things that I've always brainstormed when it comes to that is, as many people living with sickle cell experiencing those crises, coming to those clinics or hospitals and trying to find treatment for that physical ailment, physical part, there's still that I think we call it like a debrief that needs to be had after all of that. You're going in, you're in pain, you're anxious, you're stressed, maybe you're angry because of the treatment, maybe you're confused because of the treatment. And then you're receiving your treatment when they finally let you upstairs, and everything finally goes on. And then now you have to worry about, okay, what am I going to do with school, with work, with my family? And it's kind of like all right, here you go. You receive the treatment, and the day is no even having something in place for that, I think would be extremely essential, extremely important.
Are they doing enough, Alex? I'm not sure. But mental health, we're so happy to be a part of the conversation. Because 4 or 5 years ago, we were still being seen as an add-on. You go to the doctor, you get a full check from head to toe, was anyone checking on mental health? Not as much as they are now. So we're excited about that. Things that they can do to help change that is we can talk about physicians who are getting ready to retire in the next 5 years. There's going to be shortages. So funding that can help with more provider training to cross-train providers who are already in the field to help with mental health and other specialty cares, that would help. Some of the restrictions that we have on nurse practitioners and PAs, that's a different conversation. Also, funding restrictions, care coordination, that's a big one. Providers are not talking across the board, but that has a lot to do with reimbursements, but not people across the board. So, still work to be done.
I would agree with that. We're gonna have one more question and then I wanna open the floor for questions for our panelists. So my last question to you three would be, what are you hoping to see in the future when it comes to mental health? Whether it's generalized or for sickle cell warriors specifically, what are some things that you want to see happen and improve for our warriors and people in general?
I think one thing we need is more providers providing mental health services. And like I said before, we don't have enough mental health providers, we don't have enough psychiatrists. Primary care physicians are going to have to get more involved in mental health. Matter of fact, there's a big push right now to integrate mental health into primary care. Now, I work in a clinic where I see mental health patients, but it's not unusual for those patients to come in addition to having a mental illness, they have high blood pressure, diabetes, and other things, but that's not getting taken care of. Now, one thing, what primary care providers need to understand, and mental health providers, is is that, those with mental illness will die 15, 20 years sooner than average person in the population, because they're not getting their primary care needs, taken care of. So I've seen patients come in to see me, they have high blood pressure, but they've been off their medication for 6 months. So I have no problem with putting them back on it. I mean, I'm pretty comfortable with that. I'm not sure if they saw a psychiatrist, he may not be that comfortable with it, or I see them with asthma and other problems that they need to be on the medication to get treated. So I end up providing the mental health and the primary care at the same time. And that can give you some better outcomes. So we need to integrate mental health and primary care. And we need to encourage more primary care providers to give mental health management.
Shameless plug or promotion or citizen sanctuaries that provide that holistic care, that provide that all of that around care for people with sickle cell, that access to resources. They're popping up, fortunately, but they might really not fast enough. And they're in certain areas, like in Atlanta, here in Atlanta, we're right, like the next one here. But then you have the rural areas, more, the countryside areas, the smaller towns that are still going to be in need of them. So, more sanctuaries. Thank you, Tim.
I don't think the warriors are asking for much. They're asking for a seat at the table. They want to be respected. They want culture to be competent care. They want access to providers. So for mental health to continue to have a seat at the table, we're expecting our providers to be educated. And when I say that, they need to be attending conferences. They need to be up to date on current treatments, protocols, and not having patients coming to them with new initiatives, but are aware of things that can already help their patients.
Thank you all. Now, I do want to open the floor to see if there are any questions for our 3 panelists up here regarding mental health. Microphone is going to be.
Thank you, Dr. Panel. I have a question around, we talk a lot about the shortage that we have of providers, but I know one of the reasons why we have that shortage is burnout, and people living in burnout, not wanting to go into the field. So from your perspective, what are some things that can be done to prevent provider burnout and to encourage other people to get into the field?
Some of the things that can be done. We talked about the reimbursements being equal across. I talked about the nurse practitioners and PA operating in less restriction. Cross-training the providers that we currently have, the ones that got a good maybe 10 more years left on them to see different specialties. Let's start. Prevent burnout. Build more providers. Still prevent burnout for the providers who are in mental health. Oh, we have to become patients ourselves. So I have a therapist that I do see every month, every 3 months. I take advantage of the wellness center and everything that they have to offer. So that's massages and reflexology, IV hydration, things to help to decrease stress. I work for a wonderful company that understands how it is to have employees living with sickle cell. So that's also a plus.
In terms of preventing burnout for the practitioner or provider, I believe in practicing what you preach. When I work with my clients that also with sickle cell, so a lot of the things we talk about are planning for our own wellness planning. It's called the RAP, Course Recovery Action Plan. But you put together and identifying how I'm feeling when I'm well, how I'm feeling when I'm out, how I'm feeling when I'm not in a crisis, I'm triggered. And I also have one for myself. I bring my own wellness plan to know how to, not about following this next door, but putting those things together I'm a therapist. I cannot, in good faith, teach my clients care for yourself, self-care, X, Y, Z, and I'm running around like a chicken with my head cut off, just stressed out. I can't. So I have to, for me, it's practicing what I preach. I'm telling my clients to take care of yourself, rest, say no. I always say no to the 3 seconds. I can start to say no more often. Begin to really advocate for yourself. And having a support system that helps advocate for you too. As practitioners, we need those. We need to advocate for each other. Support system for each other.
I have no idea what I do. To prevent burnout. Myself, I tell people I've been practicing medicine for 42 years. They look at me like I'm a caveman or something. I've been around so long. I try to stay positive. One thing about me, I do a lot of different things. I do mental health, primary care, I work with sickle cell disease. I go to the mental health clinic. I go there once a week and see people. That's probably helpful. When you're doing this more than 2 or 3 times a week, it can be extremely stressful and can work on you mentally. You try not to take this home with you. That can be a problem. Stay positive and you're ways reminding yourself of why you're doing this. You're doing this to be helpful. I know a lot of times people don't see me. I don't know that. I don't know, they think I'm somewhere drinking coffee, socializing or something. But I'm pretty busy. I'm stretched out in a lot of directions. So I have to stay calm. I try to spend most of my time trying to solve problems. I just don't get worked up about a lot of things. I think that's what helps me. And, I have people I can talk to if I need some advice, need some input. Because doing mental health can burn you out. I often ask myself, the other associates here, how do they do it every day? I don't know if I can do it every day, but I just do it once a week. Plus, the mental health, I see it in my own practice. But you try to stay positive, you try to stay on the mission, and tell yourself why you're doing this. Don't get caught up in a whole lot of nonsense and relax, go home. I have a wife and kids that need me, so I have to not take that stuff with me so I can concentrate on them.
Tap the microphone, please.
How can we attract more people to receive mental health counseling, knowing that it started in childhood? Whatever goes on in this household, stay in this household, right? So how do we get away from the stereotypes, the stigma associated with having a therapist or having a counselor when it's been embedded? Like, what message can we use to take the sting out of people feeling that if you go and see a mental health therapist, you're Kuckelberg, or you're going to see Kuckelberg, because there's so many different images that I have in my head and memory bank about what that looked like when I was a child. Thankfully for me, I do have a therapist as well that I see every Wednesday, thank God. So how do we promote mental health? Well, first of all, thank you all for being a part of the sanctuary, and I know we now have more mental health therapy sessions than we've ever had before, so that's a plus. But how do we continue to get the messaging out, to take the sting out of people feeling that is something wrong with mental health, particularly Black men?
Talking about it. Normalizing it. And which, I took criticize social media so much these days, but one of the upsides is, it has allowed that access that, everything that goes on in the house stays in the house because before social media, everything really was in the house. Now we have a very thing go online and say, oh, this person in Chicago is going through something similar to my experience. This person in LA is going through something similar to mine. This person in this person in South the country has a story similar to mine. And so now we're having this access, and people are talking more, and we're able to access information more. I don't know if people are talking more, but we're able to hear it more now. So we have access to more of that information and being able to continue those conversations, to continue. I call it thing a thing. I use that phrase in therapy a lot. Let's call it thing a thing, which means let's call it what it is and let's talk about it. Instead of a problem, let's identify it and let's say, hey, this is something that's going on. What can be done? What's being done? What could be done? What could be not done? But starting those dialogues is very important. I just say yes.
Yeah, I'd like to say, I do have more patients coming in now, requesting, mental health, not sickle cell, not all patients. So that means that the stigma of having mental illness is less than what it is now. So I know back in our community, it was taboo to talk about mental illness, but I think more people are beginning to want to discuss it. And God knows that in the climate that we're in now, we need to be able to discuss illness and be able to talk to somebody. The biggest complaint that patients have when they go seek mental illness, they say that the provider won't let me talk. That was the biggest complaint. So I think one thing that providers, what we need to do is let patients talk. And matter of fact, just sit there talking is therapy. Let them get that stress out of them, let them talk.
Any more questions from the audience? Wait for the microphone so they can crowd can hear you.
But I think, Dr. Powell, we're onto something really big here with our provider training, and I think we need to add mental health to that component of it as well. While we're out teaching all over, Georgia, the hospital, universities, and all that, we should add, we should add this portion of it to provider training, because I think that can be very beneficial.
Yeah, I definitely agree with you. That's something that we do give a few alerts about it during the talks, but it needs to be a lot more than what we're doing there.
We have one more?
Yeah, I want to just say, as a community health worker, if a client comes in or I'm on the phone with them and I'm speaking with them, and if they just need housing or financial assistance, I gotta be in a little deeper to talk about their mental health, because a lot of times they're in denial or they just don't want to know what's going on. So I think that with as many community health workers that we have now, I think that if we dive more into that, we allow them to trust us more, and so that they will feel comfortable with that, and you all will get more referrals. So that's
Community health workers are not clinically trained, let me be very, very careful with that aspect of, questioning. What we should be doing is just maybe have one or two questions and refer right away, because we have to protect the liability of the foundation if we start delving into a mental health patient. You understand?
Yeah, there are questions on the intake form. So what I mean by that is asking them, are you having any challenges with mental health? That's on the intake form, so we ask them those questions. If they say yes, then that's more referrals for you all. So
if, I've had some situations to where I had to immediately go to Clayton for this, about the situation. So that's really what I'm talking about. Those, and then there's another question, is pain a major problem for you on the intake form? So you should be able to discern a little what goes to, needs to be referred out to the therapist or the psychiatrist and stuff. So that was just a little bit more information from my standpoint.
Thank you. Any more questions? Oh, we have one right here.
Well, I think about, Tabitha, your comment about what goes in home stays in home. It starts very young. What do you guys do to normalize that when you think about the transition in younger people? So by the time they get older, they've already had those, therapy that's been normalized as part of their overall care.
Formalize, I would say it's back to education, just like ages 6 to 12, when we're getting into the school systems, we're talking to them about medical conditions. Mental health just as important. So to formalize, I would say more education and starting younger. Education is kind of how you dispel stigma.
Thank you. Everybody, please give us a round of applause for our coming out on this beautiful Saturday and sharing your knowledge on what you know about mental health and sickle cell space. So guys, moving right along, we're going to do one more panel and then we're going to get ready for lunch. We're going to have lunch and come back and sit, and we're going to do a presentation while we're eating lunch, just to keep the ball moving forward. Are we okay with that? We're about ready to eat again? Okay. So our next panel is on reproductive health and House Bill 94 with sickle cell warriors. House Bill 94 was passed this year during the Georgia 2025 legislative session and went into effect on May 1st, and will cover insurance policies renewed or issued after January 1st, 2026. The legislation requires health insurance plans to cover fertility preservation services when medically necessary treatments may impair fertility for sickle cell disease, cancer, and lupus. To offer a little background here, 16 states have insurance mandates for fertility preservation, and now including Georgia. But these mandates can vary wildly. Some only apply to state-regulated, fully insured commercial plans, not self-insured employer plans. For example, the scope of what counts as fertility preservation services can also vary significantly, and illnesses that are covered for these services can also vary widely. Melanie Avila Howell is a nurse practitioner at the Comprehensive Sickle Cell Center at Children's Hospital of Michigan in Detroit. She is the program leader for the Growth Clinic, a pioneering program dedicated to guiding young adults with sickle cell disease through critical transition from pediatric to adult health care. And she has spent 19 years working in hematology and oncology. Dr. Jacqueline Lee is a reproductive endocrinology and infertility specialist at Emory Reproductive Center. She is an OBGYN, and her priorities include educating people about their reproductive potential and providing them with the most up-to-date evidence-based information so they can make informed decisions about their treatment. Can we please give a warm welcome to these two young ladies? Thank you so much for coming out today. To each of you, let's start with why fertility preservation is so important for sickle cell warriors in particular.
Thank you guys so much for having me here. I just want to say I'm here on behalf of SD Red too, and Tiana Wolford could not be here today because she is a warrior herself but fell ill. So I just want to give her credit for her tremendous work in this space, and so sorry she can't be with you all because it's such a treat for her to share her story. Sickle cell disease is such a complex disease. Obviously, you guys know that. We're in this space speaking about infertility because it's so important in the sickle cell community to have that education around infertility. As Dr. Powell was saying on this mental health panel, which was so great, there's just a lack of education in this space. I work in mostly pediatric, but my role is adolescent and young adult, and I can't tell you how many patients will tell me, women and men, that they really didn't know their infertility risks. So we have to start there. It's so important because the disease is so complex and it affects their fertility. And if they don't know this, we have to do better in helping them to know this and then referring them out to the specialties that they deserve to have as part of their care.
Yeah, I just want to echo that as a fertility specialist, I see patients affected by sickle cell disease who didn't or weren't necessarily educated on the impact their treatment and their disease might have on fertility. And I'm often seeing patients where we're at a point where there are limitations of what we can do have. So I think education and efforts like fertility preservation have the potential to really preserve that for patients as they pursue life-saving care that can limit their fertility. In my world, in infertility, regardless of medical illness or background, cost and just access to care is still a huge issue. So any efforts that we can make to lower that barrier, increase the chance that people have access to the technology that is excellent, but is still not available for the majority of the U.S. population.
Melanie, how does HB 94, which mandates insurance companies cover fertility treatments in some situations, either hurt or help our warriors?
So I thought about this question when you sent it out, and I think it does both. Obviously, it's such a tremendous, amazing bill that was passed here in Georgia. I don't think we have it in Michigan. And it allows them access. I feel like the sickle cell community and patients, warriors, they have to accept certain limitations with the disease. And to be able to provide them an option with fertility preservation to, obviously it doesn't guarantee that they'll have the ability to have a family, but it gives them an option, which we need. I thought about the hurt factor because there's so much fear around the disease itself and how it affects them on a day-to-day basis, and then so important in the fertility space for both men and women. And that can cause so much anxiety, and just having that discussion in clinic is really hard. It's a vulnerable thing. We're talking about sex, we're talking about reproduction, we're talking about reproductive organs. You know, it starts in adolescence. It needs to. I mean, they are having sex at that time. Just to speak real, and just trying to level the playing field and have that discussion with their parents and knowing the ins and outs. But to be able to provide them resources and say that this may be, you may have access and you might have funding to give yourself fertility preservation, and it takes that anxiety off the table may be helpful. But I just think we have to remember as providers that that can produce a lot of anxiety in the space too.
Dr. Lee, can you tell us more about the fertility preservation and the process?
Sure. Yeah, I'd love to. It's what I do every day. So, fertility preservation typically refers to patients who would like to freeze either eggs or sperm or freeze embryos. So, it's much more involved for a patient with ovaries who's either planning to freeze eggs or make embryos, and they have to go through a 2-week period of time where they're giving themselves 2 to 3 daily injections to stimulate the ovaries. And then at the end of that 2 weeks, they go through what's called an egg retrieval procedure under anesthesia, where those eggs are removed from the ovaries and can be frozen as eggs or fertilized with sperm being turned into embryos and frozen at that state. So, I mean, cost alone, if you consider all the complexity of that treatment, is a big barrier. Geographic location, just other appointments, transportation. If you know anyone who's gone through IVF, it's essentially going through the IVF process for a patient with ovaries to preserve their fertility. And those eggs can be thawed at any point down the line, fertilized, made into embryos and transferred into the patient's uterus if they're planning to carry a pregnancy. Or if they've already made embryos, those can be transferred, thawed and transferred directly into the uterus. So it allows you to freeze at a point in time where your ovaries are healthy, in the case that time is going to pass, you're not going to be eligible for pregnancy for whatever reason, or you're going to get medical treatment that's going to compromise your ovarian function and limit your fertility. And then on the middle side, sperm as well that can be used.
Seems like it's a longer, more tedious process for the woman.
It is, yeah, like most parts of reproduction, it's a lot more burdensome on patients who have ovaries, yes.
So Melanie and Dr. Lee, in your experience in the healthcare system, how does legislation directly impact patients? In particular, the various laws across the country forcing insurance companies to cover fertility preservation for sickle cell warriors and others battling serious diseases.
I have, every day I have patients who either cancel their appointment or don't receive treatment because of the cost, every single day. And so it's not guaranteed that insurance will cover even an initial consultation with a doctor like me or any type of treatment for fertility, either, as a preserving treatment or just you're wanting to get pregnant now and are able to. So, having a mandate that requires insurance to cover that, in theory, lowers the barriers to patients even getting into my clinic and then accessing this technology that's incredibly effective, but again, not available to everyone. I think that, as you mentioned in your intro, which was so accurate, these laws have huge limitations. So, the patient may be able to come see me and freeze eggs, but in 10 years, will their insurance pay for them to make embryos and get pregnant, which is another huge cost. And even just, which types of insurance are actually going to fall under that law is pretty heterogeneous. So every law, not every one, but the one that we have in Georgia is a step in the right direction. It is not the solution for the cost issue.
So I think Dr. Lee can speak about the process, obviously. I think legislation also forces us as care providers to come together and collaborate because it's out there, it's known, and then we're making referrals, and I have to make referrals to your specialty and vice versa, so that it forces us to sort of recognize, where we need to provide the best care for patients. So it's wonderful to see it, and we have a long way to go. I do agree. This is a topic that we could spend all day on, and we just have a short time for this discussion. And before we wrap it up and open the floor to more questions, I want to give each of you a chance to mention what's important to this discussion, something people need to be more aware of. I think this was mentioned earlier in the mental health space as well. It's about us providers talking to our patients, our warriors. It's not talking at them, it's having a conversation, getting down into the nitty-gritty of what's really going on and how we're going to impact the care that our warriors receive. I think is the most important part of my clinic and how we run. Just to give a small plug, we started this growth clinic. It's called Gaining Responsibility, Owning Wellness, Transitioning Healthcare. So that's what growth stands for. And it's such a vulnerable time in warriors' lives, transitioning them to healthcare. I have the distinct honor and privilege of working every day with these warriors, but really, we gotta pull out what's going on in their lives, their fertility, their education. It's so powerful to see them light up when you ask a 12-year-old potentially about whether or not they're planning a family. And it's like really uncomfortable at first for the parents, but I'm like, you know, we gotta hang back and let's have this conversation. And Dr. Powell said that so eloquently, like we have to talk, we have to have these tough conversations. We have to get the real education out there, and it's not just teaching them with just speaking at them, it's having these conversations. So how do we as providers, medical people in this space really impact how we're educating warriors? Dr. Lee?
Yeah, I think I'm gonna mostly echo that. You know, I have so frequently seen patients who feel devastated by the lack of education they got when they weren't ready to build their family. And the technology we have is incredible, but it gets harder to use as you increase in age or develop medical complexities that require treatments that impact fertility. So education in those, you know, early years where you might be thinking, I don't even know if I want to build a family, can be really life-changing and set people up for success in their reproductive years. And, you know, I'm catching people often on the tail end of that. And so it's worth asking even if you're not sure if it's something that's important to you.
Thank you. Are there any questions out of the audience? Yes, Dr. Person? Dr. Person?
Hello. I have a quick question as it relates to infertility and sickle orders. Is there some type of funding available for those who are sickle orders and want to freeze their eggs? And maybe they have insurance starting out, or maybe 10 years later when they want to actually go forward with pregnancy, you might have those eggs, the insurance has changed. It's like you save the eggs and 10 years later you save the baby, so they prevent measures. So what? Is it for funding sources, grants, or something for those who are trying to take the initiative to, you know, save their family, preserve their family history, as well as to save their eggs, and then down the line, they doesn't work out.
Yeah, so there are family building funds and grants that, you know, are a band-aid on this insurance issue for patients who have cryopreserved, you know, eggs, sperm, or embryos. I think the idea is also that, you know, preserving on the front end gives you time to build, like hit pause on your reproductive future and build resources over time and potentially be in a position where you have an insurance that covers it. We're seeing a huge improvement in employers actually offering insurance for these types of services, which used to be limited to just, you know, limited altogether, mostly out of pocket. So specifically, the question you're asking, like about people who froze for fertility preservation reasons and then want to use them down the line, not specific to that, but there are grants in general helping people build their families or more. Actually, there's insurance paid for it, but you know, that list is growing.
I think a lot of insurance, I know we run into this, it's insurance dependent. SC Reddit is an organization though that they have a lot of grants that patients can submit and potentially have resources, and she's working towards more grants. A lot of it is grant funding. I know for myself, I've looked at this for patients and within Detroit, and it really it's grant money, and if they don't have the resources, it's not an option for them. LaToya?
Thank you. Appreciate you all being allies for just the need for comprehensive sex and reproductive health education. We talked a little bit before about collaboration with other partners. Are there other chronic conditions or health diseases that you've identified that are in need of this reproductive pathway that sickle cell warriors could align themselves with to promote some of these legislations at the state level or federal level?
It's a great point. I spent most of my career in oncology, and I know, again, there's like this roadmap of how they can get fertility preservation because of chemotherapy, right? And even at a young age, when I would take care of kids in the space, it's like they were talking about it, it was accepted. Were ways of them getting better funding. So we lean on the oncology space a lot in sickle cell because the warriors deserve that just as much as oncology patients do. We talk about this all the time. So we are trying to piggyback, I know in my clinic on that space, on collaborating. One thing we've done is we've incorporated having OBGYN into a clinic. It's called Flow Clinic. I did not name it. I think it's horrible. But the bleeding disorders clinic did in my space. It's multi-D. We bring OBGYN there. And it's like a huge stride because we're moving that in a multidisciplinary space, which rarely happens in sickle cell. And they meet with me, and they meet with our hematologist, and they meet with the OBGYN so that we are this familiar face. We know their disease. We know what's impacting them, that they have this narrow fertility window, and like forcing the OBGYN then to like be involved in that discussion and verifying information, and they follow up with me. So I know that's a lot in a roundabout way to say. I think we're using oncology and I think that's part of how these bills have gotten passed is because most insurances will pay for that in that space and not in sickle cell.
House Bill 94 includes, along with sickle cell patients with lupus, so that's another group, and other non-malignant hematologic disorders could be included as therapies progress and become more successful, but also potentially infertility.
I've done a lot of study about fertility, only because I had a girlfriend that went through that process and she spent hundreds of thousands of dollars and unfortunately was never successful. So I know that there is a huge risk, right, when it comes to storing your eggs and then using them later and then the injections and all that, and so the baby out of a boatload of money, right? So my question is there any type of editing of the eggs that you can do to prevent, because as we start aging and all that Down syndrome, the nervous system, all the issues that may go along with, a person waiting later to have kids, are there ways that you can use it? Edit the eggs or edit the sperm, or only people who decide to become a mom or later. I had read about that with Janet Jackson, I said, oh, she had a baby. Well, they didn't know this. And she went and had those eggs edited to take out any chances of Down syndrome and things like that because she was older.
So a lot of patients who are conceiving in like their mid to late 40s and 50s are using eggs they froze when they were younger women, or they're using eggs from a younger woman that were donated. So an egg donor, we have the ability to test embryos for genetic conditions, but not edit embryos. So you can look for, trisomy 21, which is Down syndrome, or other, we call them aneuploidies, and not use them, but so often as you age, we see it more precipitously late 30s, early 40s, the majority of eggs are going to have those errors and not be compatible with life.
Yeah, you have a question, Janet?
Dr. Lee, you talked about all this technology that's available, but that, so I'm curious to know, could you take me through like actual numbers? How much money are you spending if you're trying to do this?
Totally. So I'm going to speak just to my personal, clinical experience. I think it definitely varies clinic to clinic, but usually a patient who wants to freeze eggs is going to cost them like $15,000. And if you wanted to do IVF, I think the embryo is supposed to be $25,000. And that's the procedures, the ultrasounds, the anesthesia, the medications are so high cost, the injections, and there's some legislative efforts to reduce those costs you might have heard of recently, and we still haven't seen those come to fruition, but there is a lot of murmurs and interest in lowering the costs. But the care itself isn't that expensive when you think about like medical care is expensive. It's just that if you don't have any coverage, if you get an MRI, that would also be very, very expensive, but insurance isn't thinking it generally covers it. So 15 is what I tell patients for using 25 for making embryos and doing IVF, and probably about $500 to freeze sperm.
Well, thank you so much, ladies, for coming and to speak on the subject matter. Please give them a warm round of applause. Thank you so much. So I do know that was a lot of information to process. We are going to take a quick break. There are some lunch boxes out here for you guys. Our staff is outside waiting to assist you with lunch. You grab a box, come right back in, and we'll get started with our next speaker. Thank you.
Hi, I'm Ava, your advocacy virtual assistant. It's time for a word from our sponsors. Thank you. Pfizer. Agios. Beam Therapeutics. T-Remote Blood and Cell Technologies. Find Federal Dispensary, located in Smyrna and Decatur. Scan the QR code to enter for a chance to win a free service at the Sickle Cell Sanctuary. Scan the QR code to attend the 4th Annual Black Tie Gala, Diamonds and Tuxedos, Saturday, December 13th. Scan to donate to the Sickle Cell Foundation of Georgia that directly helps the warriors we serve.
Hi everyone, I hope everybody is enjoying their lunch. There's a little bit of fuel with Jason's Deli sandwiches. We're going to go ahead and go to our third speaker of the day. You can still continue to eat. Our next speaker is a well-known person in the sickle cell community. He has been a tireless advocate for warriors for years. And when it comes to sickle cell-centered legislation, there's no bigger supporter than our very own Andy Lord. In fact, yes, give him a round of applause. He deserves that. In fact, he is a lobbyist for the Sickle Cell Foundation of Georgia and is an integral part of helping the foundation achieve its legislative goals. Andy started his own lobbying firm in 2006, Georgia Capital Solutions. His firm specializes in state legislation related to healthcare, education, and appropriations-related policy. Andy joins us today to bring us up to date on the most important legislative issues for the sickle cell community in the upcoming 2026 General Assembly. Thank you so much, Andy, for joining us.
Good afternoon, everybody. I want to start with just a very brief personal note. Most of you all know by now, for no other reason other than Gloria Fraser's commentary yesterday, that I lost my dad last week. And I want you all to know that the number of people in this room that approached me yesterday with their stories of loss and of support and of encouragement. And for those of you all who found me again this morning, and for those of you who brought me a card this morning and hugged me all day yesterday and today, I want to say thank you. It's been thank you. I know, and I will be happy that it's been a rough go for me. And there's just no way around that. And I am reminded with the love that I received from you all yesterday and this morning, I am reminded of my first ever intersection with sickle cell and Gloria Fraser, and it was when she noted yesterday, as we were giving out these awards in her name, she noted that the first time she and I ever met in her office was about an education bill. She talked about her sickle cell bill. I told her I had the trade and that I wanted to help, and she said, "Get out of here." As she told it, right? 3 times she told me to leave her office. And I'm like, "Lord, it's serious." And she asked me, when she finally believed me, she asked me to come down that year to be the keynote speaker at the Sickle Cell Center that she hosts every year for the festival. And of course I agreed. And I went down to that event in Augusta, Georgia, and I walked into a ballroom. There were 400 people. This beautiful buffet on the back, and this white tablecloth candlelit event that she does every year. And I was the only white guy in that room. And everybody was talking about me. Not bad talking about me, but kind of like, "You sat over there, and I could hear that rumble. And I walked into that hallway, and I was looking around for Gloria. There were 3 ladies in the back of the buffet line with their empty plates waiting to go through. And they were looking at me like, Like the thought bubble was, is there a scar in there tonight? Is there pro wrestling? You know, and they look at me and they're very kind. And they say, can we help you go make it sickle cell different? And they're like, yeah. And about that time, Gloria saw me from across the room. She said, hey, and I go sit down at this table. And she had told me when she invited me, she said, hey, I want you to be the keynote. I'm not telling anybody that you're white. I want the shot, right? She got it. So I got up and I did my spiel about the bill Gloria was working on that year and sickle cell in general. But the notable thing I want to share is a bookend what I just shared about the love I have received from you all these last couple of days is when I finished my remarks as the keynote at that sickle cell. Y'all, I had a line of people waiting to speak. And every one of them said, we're cousins, we're family, give me a hug. I mean, I have never, it stands out to me today. The love I received that day, the instantaneous welcome and connection that was presented to me that first day. I felt it again yesterday, today, this weekend. I want to thank you all again for it. I want to tell you all in this tough time for me, right now, on this Saturday, I'm exactly where I want to be. And I thank you all. So on a personal note, having said that, let's talk about dumpster fire that rages right now in our country with regard to healthcare, with regard to appropriations, with regard to disease. I want to talk about the diminishment of the CDC, the diminishment of the National Institutes of Health, the diminishment of our own state Medicaid office right here in Georgia. And let me tell you something that's real. But the signal to me that we are receiving is that we must now step up. The CDC may not be here to save us. The NIH may not be here to save us. You know, Barack Obama said when he was running, we are the ones we've been waiting for. Right now, y'all, it's us. We are the ones who are going to have to carry this torch forward in the face of CDC cuts, NIH cuts, healthcare grant cuts. It is us. We now bear this responsibility to pick up this slack while we continue to fight for CDC and NIH. But we cannot lose a step in advocating for our citizens. I want to tell you all to bring this down to the Georgia level, on this federal level. The cuts that are expected in Georgia this year relative to last year, depending on who you talk to, and on which member of appropriations you talk to, the cuts that we are about to sustain in this state range from $2 billion to $3.7 billion. More than me and Tabitha make in a year combined. I want to make sure I got the understatement. On that award, Dylan, we are looking at billions of dollars of cuts in the state this year, just relative to last year. There's no hyperbole in those numbers. Billions. We don't know what's going to happen with the shutdown. Maybe some deals are made. We don't know. Right now, this is a prolific budget cut. Here's an additional reason that's very important. Georgia, by constitution, has a balanced budget. Here's what that means. There is no state debt. There's no state debt because that would be illegal. The way it works in Georgia is there's a fixed pot of money. It's called the governor's revenue estimate. And borrow money in Georgia. everything must be funded with the mixed pie. That mixed pie just went, it just got smaller. Our opportunity to extend appropriations. We talked, Lord mentioned yesterday, we have fought for nearly a decade, and got our budget of $2 million a year from the state. That's an accomplishment, that's amazing. It's a risk. It's a risk. We have to fill this down. Led by CDC, NIH, Department of Medicaid, Department there, the uncertainty that we're confronting in the healthcare space is prolific. And we will have to spend it. It's going to impact our appropriations request this year, et cetera. But I want to quickly review what the Sickle Cell Foundation of Georgia's legislative agenda is going to look like this year, qualifying that there is so much uncertainty. And we will have to be able to get it. We're going to have to be able to adjust because we don't really know what's coming. But I want to really touch on a few issues. I want to touch on appropriations. I want to touch on community health workers. I want to have a quick follow-up on this fertility preservation bill, and also the cannabis conversation that we had earlier, which is just wow. I tell you, every panel I've seen, I have learned something, and it's been fantastic. That cannabis panel was just A+. Okay. All right. So let's talk a little bit about this claim. It's just a heavy. I'm going to try it one more time. If I hold it, I will have to render the rest of my remarks in haiku. And just right here. So from the word go, let's understand again that we're going to be dealing with almost certainly a diminished appropriations pie. As you all know, what we do with concurrent appropriations that we have earned from the state year in, year out is we have invested in the satellite centers, the brick and mortar satellite centers in our population areas around the state. We have the traveling hematologist, mobile health hub. We do provider trainings, physician trainings, mid-level trainings, so folks know where to go. We have extended these resources to community-based organizations. For many of you all that are out on the ground in Georgia, all of that is in the budget right now. All of that is as much at risk as it is for being increased. Our opportunities for increases in those budgets this year is going to be small. Our risk for losing some of that money will be large. We are not alone in that boat, but we are in that boat. So we are going to have to rally around that. But there are some other issues that your foundation is going to be working on this year that are much less appropriations intensive. One of those is community health workers. Is anybody in here CHW? We still have, they're in that? Okay. As you all know, the CHWs have become the connective tissue for getting our sickle warriors the care that they need to deserve. Patient navigating them to the resources that are available in their community is absolutely critical. Following up on care, following up on are you taking your medications. Remember your appointment is next Tuesday. Here's a resource you can access. This is the lifeblood that keeps our sickle community and our sickle patients on the forefront. We will be looking to follow up on legislation that we filed last year, which certifies these CHWs in Georgia, that allows these CHWs to be Medicaid reimbursable, so that we can incentivize more folks coming in. And the more that we see our rural hospital system failing in rural Georgia as it is, rural hospitals are closing, those are becoming further and further away from their source of care. There are already dozens of areas of geography in Georgia that are greater than 80 miles away from the nearest sickle cell care. Y'all, it's unacceptable. It's intolerable that anybody, you can have a sickle cell event and get in your car and drive for 80 miles and hope you can see somebody. No, it's not okay. What other disease state confronts that situation? I was trying to figure out how many the other day, over 0. Not acceptable. This foundation is working to fix that, and we will. But what we have done in the meantime is establishing these satellite centers, and then we have that mobile unit, and you know what our criteria for the mobile unit is? We will bring it to you if you are greater than 80 miles from here. Last year, this was referenced yesterday, we got the House to put in funding to give us a whole brand new mobile unit, so we'd have two to cover the state. We could go into more geographies. The Senate cut that budget entirely. We went from $850,000 of additional money to zero. We will seek to get that reinstated. It will be a greater challenge this year because of the appropriations that I mentioned. Community health workers are there. We need to grow this population. The cuts to healthcare, the prospect of having an additional 300,000 to 400,000 Georgians become newly uninsured. About 300,000 to 400,000 currently insured Georgians on the current trajectory that we are on. 300,000 to 400,000 currently insured Georgians will become newly uninsured next year, and they will extend that premium tax credit, which is part of the dumpster fire that rages in DC right now. 300,000 to 400,000 Georgians. And whose numbers are those? Those are numbers of the insurance companies. You all, I fight the insurance companies all day, every day in Canada. Because I not only represent sickle cell, but other disease states too. I fight those insurance companies. I've been going hand in hand with the insurers in the legislator's office and saying, if you see us together on something, there must be a real problem. Because we do nothing but fight. I do nothing but fight insurance companies. We have a serious problem. Everybody sees it. But the solution is harder to come by. So we will be working to appropriate to get that mobile unit back in to further support our wellness center here in Benjamin East Parkway. We will be working to get that mobile unit reestablished. We will be working to increase our funding to deliver to community-based organizations across the state that are doing work on the ground. That is on our agenda, but a tough climate, CHWs are a little easier lived. Fertility preservation, I want to go back to that for a minute to give you all a forecast here of what we're seeing. The sponsor of House Bill 94 last year, the fertility preservation bill that we were discussing on the panel earlier, is a guy named Eddie Lumsden. He's a Republican from up in Rome, Georgia. He's a really good guy. He called me last week and he said, so the bill we passed last year, for a little bit of context, only compelled private insurers to cover this cost of fertility preservation. It did not extend that coverage through our Medicaid program. There was one reason for that. We had it in the bill initially. It had to be amended out because the governor's office called me in and said, we ain't doing it through Medicaid because we haven't found the money to do that. This goes back to the fixed pie we talked about. The governor's office says, if you leave Medicaid in your bill and you pass it off the House and Senate floor, we will need to. Got a very direct message. That's not the governor being hostile. That's actually the governor being respectful. I'm telling you what it is. I'm glad that we got that courtesy. We removed it from the bill and said, all we can do is get it for private insurance. We'll do that right now. We're going to take what's on the table. We're going to keep fighting for what just got taken off the table. This is the posture we now find ourselves in. Fertility preservation, okay? We now have to go back and get that added to Medicaid. We're doing it in an environment where Medicaid is being cut, not extended. So we need to be clear-eyed about what we're confronting this year. It's going to be a very challenging year with regard to appropriations. So we will be seeking to extend that fertility preservation for sickle cell patients beyond what we have currently accomplished or what we accomplished just of last year. We're walking straight up the hill. I don't want to be cynical and I don't want to invoke pessimism, but I do want us to be clear-eyed about what we're facing. And again, we're not alone. Anybody in the healthcare space is confronting these dilemmas that are budgetarily influenced. So we are not alone, but we are at risk. And some of the gains we have made in the sickle cell space are at risk. CHWs can help with that, extended fertility preservation can help with that, these are low-cost items. Appropriations for our, again, our mobile unit, and our satellite centers, they are at risk. We will still be asking for more funding. That won't be a tone deaf request. We will be on offense because, as they say, sometimes being on offenses are best defense. And by asking for more, we're giving them something to say no to us about without cutting into the budget that we currently have. And that will be a back channel kind of strategy that we have on our radar here at the foundation going forward. Another thing that will be on our priority list this upcoming year is going to be the cannabis issue. So again, as you all know, years ago, when we were first contemplating cannabis, medical cannabis legalization in Georgia, my first thought was, I just got so much out of that panel, and it's so important that we get prepared for this. I remember when this, the prospect of this cannabis legislation first came up in Georgia, 10-ish years ago. And it was a bill that was introduced by a House rep who's no longer serving. His name's Alan Peake from Macon, Georgia, so everybody hears from Macon. And it was called Haley's Law. And Alan Peake, a conservative Republican from Macon, had this young child in this district named Haley who was having these seizures. The family was passionate about how helpful cannabis was to their child, that they were having to break the law, as we said earlier on that panel, having to break law, federal law, to give their child what they wanted, or what they saw fit as parents. But it was illegal. They convinced Alan Peake, Representative Peake, to carry this legislation for them and get it across. I knew Alan Peake well. He called me in his office. He said, I know you work with some disease states. Can you help me with this thing? Can you get your grassroots going? Can you get your lobbying going? And I was like, Alan, I mean, I can. But I mean, this is, we're in Georgia. You know, this is a dead end street. I mean, 10 years ago in Georgia, I would have lost my house and bet that this bill was even going to get assigned to a committee, much less have a hearing, much less pass, right? So we came down, he's like, now we need to have a plan. Here's my plan. These are the gymnastics we have to go through in Georgia. And all this is going to culminate into something actionable for us. So Alan Peake says to me, I got a plan. You know, all my Republican colleagues here in this chamber, they all hate governments. You know, y'all heard the line, right? Well, right, business, good. You know, we all get this. We need to understand, y'all, that in Georgia, Republicans have a dominant majority in the House, a dominant majority in the Senate. They got the governor's office. They got the lieutenant governor's office. They got the insurance commissioner's office. They got the AG's office. You could love that or hate that. We're a bipartisan organization. I don't get that. We just had 2 Republicans up here that have gone to bat for us. So I'm not trying to characterize, but we also must be clear-eyed, you know, about what we're confronting. So I say to Alan, I'm like, yeah, I need to hear this plan. I need to hear your plan for getting 91 members of the House to legalize marijuana, which is how our detractors frame it, which is why the messaging we heard earlier is so important. He said, well, here's what I'm going to do. I'm going to go to my crazy caucus. That's his term, not mine. I'm going to go to my crazies. I'm going to tell them, we're not going to let the government tell these families they can't do something to their children that they want. That's government control. That's government overreach. I deserve that right as a family. He made this whole thing. He flipped the script on this. He said, I'm going to make this an anti-government. Government can't tell you what you can do with your kid. And I was like, good luck with it. We just fired up one. It's about this big. You know, we sat there and kind of gave him out and said, Alan, I don't know, man. I was like, look, it's worth a try. I'll help. He went and got his crazy caucus in his term, the crazy faction of his party, as he described it. They helped sign the bill. Yeah, you're right, Alan. We're taking on the government. was good. They all signed it out. And he's like, hey, look at all the Democrats to sign this thing, so I can put 90, there's 180 members in the House. We need 91 votes to get a bill out of the House. There's 180 members. All you need is 91. My favorite part of my job is that I can lose 89 times and do it. So I said, absolutely. I went to the Legislative Black Caucus. We have the largest Legislative Black Caucus in the United States of America, right here in Georgia. We must do that. I went to the LBC and I said, hey, could we sign on? Could we send a message to every member of the LBC to go sign this bill? Lester Jackson was the chair at the time. He said, yeah. He sent out that message. We went and got the signers. We loaded up that bill with signatures. It was bipartisan. Everybody was in. And that bill just sailed through. And then it got to the Senate and did the same thing. And I was like, Alan, I would have lost my house in mad respect. You got this done. But in that process, because the foundation had been active, we're an everyday footprint at Capitol. If they are in that building, I am in that building. That's what Sickle allows me to do. That's what Tabitha allows me to do. I go walk the halls of that Capitol. If they are in, I am there. They see me all the time. They hear me talking about sickle cell all the time. Alan Peake knew call me about sickle cell, and I said, Alan, of course I will help, but sickle has got to be on the list of approved conditions. That first year, we passed that bill, and we were in. That's what your foundation. This fertility preservation bill, you know what we said as a foundation for our sickle cell patients? We said everything that improves the quality of life of our warriors, we will not try. Fertility preservation made that list. We want our warriors to fight their fight. And we are going to fight this fight until done. And we are going to create better access. No matter how rural you are. Rural is one of the hardest words for me to say that way. Rural. We're going to fight for this access. We're going to fight for your fertility preservation, and we're going to win. We're going to fight for CHWs, we're going to win. We're going to fight for more mobile units, and we're going to win. But you all have a role in this too. So my call to action for you all today, I'm not going to ask for a show of hands. I'm not going to show. But think to yourself for a moment, if you're sitting in this audience, if you cannot tell me off the top of your head who your state rep, I'm not talking about Congressman, I'm talking about down here in Atlanta at our Capitol. If you can't tell me right now who your state rep is and who your senator is, you're doing it wrong. That should be on the tip of our tongue. And we've got to take that relationship with that rep and senator and build that relationship. And sometimes that's just a cup of coffee. And you all think this is intimidating. I understand from a distance it is. But y'all in Georgia, we have a citizen legislature. We are in 3 months a year. These reps and senators each get paid $18,000 a year for their job. And then they go to work. The 9 months of the year that we are not in session. These are just folks. We are the experts. They are not. I talk to folks, I don't really want to talk about rep or senator because I'm afraid they're going to be like, hey, what about line 2490200 on page 34 of the, you're not going to get that question. What they want to know is, are you in my community and this is an issue you care about on my radar? Look at that little ticker tape thing going across the bottom of your screen on election night and watch how many of these races in Georgia are decided by 300 or 400 votes. They know they're skinny on some stuff, on some votes. So when you go and you speak to your rep or you speak to your senator, they know that you also work somewhere and have coworkers. They know you've got family. They know you might go to the church up the street and tell everybody. They regard you as a voter as 100 voters. And you can ask them. In fact, I wish I would have asked them when they were up here. When they hear, I go talk to the admin at the offices that receive these calls for reps and senators, and they will tell me, for every call we get, we assume there's at least 100 other voters that feel the same way in that district. So your outreach your email, your phone call, your single phone call, your single correspondence with a legislator has the power of 100 by their own admission. So your voice matters. If you don't know your rep or senator, I urge you today. You can do it while I'm talking, you can do it on your next break. There's a website, it's called Open States, plural, openstates.org, I think. And you can put in your address, and it'll tell you who your state representative are. It'll tell you your phone number. It'll tell you everything you need to know about them. If you want to meet with them, all you have to do, you can call them directly, of course, but all you have to do if you have any trepidation is call me. I know every one of them in that building. I will call them and say, I want coffee, I got one of your constituents, we want to talk sickle cell. We will find a time and place that serves you, and I will broker that meeting, and we will go break bread with anybody that will help us on the party. And I can give you the backstory on each of them. Here's what they're going to say. Here's what the pushback's going to be. There's some folks that we already know are with us. There's some folks we know are already against us. And there's some folks that are just sitting on the fence. But I will also say this. Each of the last 4 election cycles in Georgia, there have been between 36 and 43 brand new members elected, right? Brand new members. There is a churn that goes on in the Capitol. Our job is to make sure that we are talking every year to a rep or a senator about this agenda and why it's important. Our job is to story bank. When you're in your communities and you yourself or you as a healthcare provider come across a particularly compelling story, somebody that did have to drive 90 miles, somebody that did lose their job because of their condition, these are stories that we want to catalog so that we can deliver them to that rep and senator and say, this is what's happening on the ground. In fairness to these legislators, they hear from 50 people a day that say, we got a better way to do it, we're this disease, and with that fixed budget, legislators look right back at me and say, hey, so you want me to give you more money for sickle? Where do you want me to take it from? Childhood cancer. We get good questions. It's fair for them to ask that question. They can't just pay for everything. It's a fixed pie. That's where we go back to that constitutional amendment for the balanced budget. So our job ahead of us is we stand right now, unfortunately, at the bottom of the hill. It's got a fair amount of broken glass. It's just been thrown. I'm not going to see what but there's a lot of broken glass on an incline that we're going to have to walk up. And we don't have some of the resources we've had with CDC, NIH, healthcare grants to help us anymore. It's time for us to step up. Nobody should leave here today without knowing at least who their rep and senator are. And then letting us know. If you look it up and find it, write it on the back of your name tag and turn in your name tag to us. We'll put it on the spreadsheet. And if that vote ever is critical to the passage of fertility preservation, if it's ever critical to the CHW, if it's critical to appropriations, if your rep or senator is a swing vote, we will call you. We won't call you otherwise. We're not going to blow up your phone. We're not going to get a million text messages. This will be hey, we have somebody in Allen's district. Let's reach out to them. So my call to action today is please do not leave this building today without knowing your rep's name, without knowing your senator's name, and without letting us know that. We want your name, who represents you. And my commitment to you is on your timeline, I will broker that meeting and I will help you initiate that relationship so that when the chips are down for us, during the dumpster fire that's about to start up here in January at our own Capitol, that when the chips are down for us, we are a step ahead of the game. Thank you all very much.
Are there questions? Yes. So, and I want to make sure that everyone understands that the suicide budget is just not, it's 2.7 million. However, we have very high so impossible altogether. So if you're civil, they don't know to pull these off in subsets of organizations that are getting money. And so that's all we're trying to talk about. And so that you said that, because
Yes, it is critical for people to know, or not, personally. Gail Davenport, who is my representative in Clayton County, she is phenomenal. She's a huge supporter of sickle cell, and we can always get her to do whatever. But you are so right. Everyone in this room needs to know their their city representative and get a call with them so they'll know that you're there. And like, hey, I work with over 55 people. We're all about sickle cell. You know, I know our vote is very important to you. You know, we want to make sure that you are on our side for sickle cell. And then just be very honest, like, where do you sit with sickle cell? And let them tell you either yay or nay.
Yes.
And then you can understand from them when they say, well, you know, well, tell me why. And they'll actually tell you. They'll tell you why they're not sure. And most times it's not just because they don't want to support sickle cell, it's because they have other legislations too that they're sitting on.
That's right. And also, let's not presume that our legislators in the citizen legislature even know what sickle cell is. And you know, my story about how, that many of you all have heard about how I found out, you all, they didn't do newborn metabolic screening for sickle when I was born. But by the time my son was born, they did. They detected it in my son. And that's when my wife and I went and both got tested. And that's when I found out about it. That pediatrician for my son told me when that test came back positive for sickle cell. My wife is also white, and my son is as Casper-friendly as I am. Y'all hear me joke, I'm the white guy from the Eddie Murphy movies. Like, there's nobody looking at me going, well, I wonder if there's a little, I mean, you know, you know, if our physicians did not know that Casper could have the trait, how do we expect our legislators to know? If a pediatrician didn't know that, if they had to, they retested my son, I'm sure it was a mistake. The pediatrician, and then they told me that. So let's not assume that our legislators get it. Let's not assume that they're not helping us because they don't care. Let's assume they might not be helping us because they don't know. And that falls on us, not them. We're the advocates. We're the ones that have to educate them. They are not, they weren't born knowing this.
That's question for when snatch off the stage. When would be the best time for a person to meet with their representatives? Because of course, we're back in session in January. You know, they're very, very busy in January. So when would you say is the best time after session is over, after crossover? When would you say is the best time for a person in Georgia to meet with their state representative?
Day before yesterday. We're late already. And as you said, quick context, in Georgia, we do have a citizen legislature. They're typically in January, February, and March. They are off the rest of the year. They do study committees and hearings and information collection. They are not gathering in typically past March. And typically, as you indicated, if you wait until session starts, there's a tsunami of bills. You can't get their attention. Off session is when you count your votes. In session is when you bring those votes home to the House floor. So our job is now. Now we're coming up on holidays, et cetera, and different folks have different schedules. But I will tell you, if half of us left this room understanding who our legislators were and either did initial outreach or you all connected with me and let me do that outreach, half of us, by the time session started, we would be well served and better positioned to not only protect the gains that we've made, but to increase them in a very difficult environment.
I had a question. You think that we would schedule your representatives to come to the foundation and then have them meet with all of the staff one by one and for them to be educated? So could we do that, arrange to do that for now? And to go ahead and start something this on schedule to come to the foundation?
100%, and I want to extend on that. And if you all didn't hear the question, Tabitha was asking, you know, could we get some of the legislators to our wellness center, for example, or our offices for site visits, so to speak? And the answer to that is yes. But as important, for every one of you all that's a CBO, community-based organization, that we intersect our network with. Through the funding we get, we pass on to those CEOs, for example. For any of you all that would like to have legislators, the delegation, I was talking with our Savannah team just yesterday. Savannah is very important because many of the House and Senate members on the Appropriations Committee are from Savannah. And I was saying to them, let's do a site visit. Let's bring them in to our FQHCs, to our brick and mortar satellite centers. Let's bring them in on a day where we're doing events so that they can see the boots on the ground that we are in their communities. Because too many of them want to dismiss this as an Atlanta problem.
Yeah, can we, I know Angela Shepherd is very, very much in bed with the residents down there. They have a long-standing relationship. She knows them very well. So Savannah is a hotspot for us. And every year we call Angela, she gets on the phone, she gets the representative, her and some of the warriors go to the representative. So Angela, if you're still here, thank you so much for that. She has a beautiful, phenomenal, powerful relationship down there. How do we get the other nonprofit organizations that serve the community connected to their representatives in that way in those different cities? Would you say for us to have health fairs with our mobile health hub? What would be the best way to attract them to even want to come out and support? And that's my last question, I promise.
2 thoughts on that. One, we can have an internal metric. And y'all don't throw things at me when I say this. Where we say, hey, with the simple funding that we get, that we pass out to the CBOs, one of your criteria for getting it is to have a site visit with your legislative delegation. That's one. Another one is, and we've talked about this so many times before, we have this mobile health hub that is beautiful, and it's all got all the graphics on it, and it is inspiring. As I sat here with Chairman Butch Parrish yesterday when he was getting his award, and he and I were talking offline, I said, Mr. Chairman, we have screened over 100,000 Georgians with this mobile unit. And he said, I've told him this many times, but he was looking, dang, 100,000. I told him that every year we go to national appropriations. But another way to do it, let's bring them to our satellite centers. Every time that mobile unit is going to make a stop, or even if we need to create some stops, we take that to areas of need. Everywhere that mobile unit goes, the legislator that represents the district that we stop in should be invited. Yeah. Yeah. And that's why it has to be a little more personalized. This is work. This is, the email matters because we have to overtly invite them. But they do get them, in fairness to them, if you're a state rep, I mean, you get 400 emails a day. What it really is, we're going down to Swainsboro, which is where Butch Parrish is from. I need to know, I call Butch. He and I are buds. I say, Butch, we're going to be at your public health office from this time on this date. Please come out. And then we put Butch in the middle of a bunch of sick cell patients and take a picture and put something in his newspaper. Solid goal for him. All right, thank you.
Thank you, Amy, for that update and letting us know what's going on in the Capitol. We really appreciate all that you do for the citizens community. The final panel of our legislative conference focuses on care coordination and highlighting how it maximizes efficiency, reduce costs, and increase favorable outcomes for sickle cell warriors. As many of you know, sickle cell warriors often have to navigate one of the most fragmented and inequitable corners of our healthcare system. They move both between emergency departments, primary care doctors, hematologists, and pain management clinics. Often, there are no centralized system for ensuring the continuity of care. Imagine if a cancer patient had to deal with that. Would we probably say there'd be some uncertainty that their survival might be in jeopardy? So, we know that when there is a coordinated care, it can transform the outcome for sickle cell disease patients. With us to talk about that, we are here with our care coordination, a trio of experts. Tabitha McGee, our CEO and the Sickle Cell Foundation of Georgia. Under her leadership over the past few years, we've seen a major focus on coordinating care for sickle cell warriors. Tabitha's vision and work in this area has helped move the foundation to the next level when it comes to carrying out its commitment to coordinating care. Helping Tabitha carry out that mission is Danita Battle. Danita manages the foundation's community health workers and programs. Then we have Bernard Bridges, Director of Health Education and Outreach. Along with Dr. Powell, he has a long history of providing medical care and fostering relationships within our community. This has opened many doors and formed new and meaningful and much-needed partnerships. Last but not least, we have Ms. Jeanette Newman, the Director of Operations at the Sickle Cell Foundation of Georgia. Jeanette oversees the foundation's programs and initiatives aimed at supporting those with the sickle cell disease in Georgia. She is also involved in developing and implementing the Access to Care project, which focuses on improving healthcare access and coordination for adults with sickle cell disease in rural and underserved areas. Please welcome our panelists.
Mic check.
Thank you, panelists and coworkers, for being here and sharing a little bit about what you do on a day-to-day to our audience and to those who are watching on the live stream. Danita, let us start with you. Tell us exactly what is coordinated care.
Care coordination? All right, so at the Sickle Cell Foundation of Georgia, care coordination is one of the primary services that the community health workers offer to individuals living with sickle cell disease and their families. So the coordination of care is actually number one, the intake process, getting basic demographic information on the client, getting a little bit of background information about their sickle cell disease, getting information about their regular care practices that they have, maybe visiting their primary care physician, visiting their hematologist, and any other specialty care needs. And one of the things that the community health workers try to focus on are what methods and modalities of care that they may not be receiving. So if we encounter a client that is out of care, let's say from a primary care physician or a hematologist, then the coordination of care for the community health worker looks like, okay, let's see where the barriers are. What's stopping you from going to your primary care physician regularly? Why haven't you seen a hematologist? Or if you're seeing either or, why haven't you been in a long time? What are the barriers? And so once we get that information and we address that, we assist the client by being the middleman, so to speak, and helping them to get back into care. So that may mean assisting them with transportation, that may mean assisting them with getting access to state-funded medical benefits such as Medicaid or Medicare, so that they can receive services. Or if they don't qualify for Medicaid or Medicare, then we try and make sure that they are in care at a facility that offers sliding fee scale for their medical services, which more than likely is a federally qualified healthcare center. So we serve as the middleman, so to speak, in between the client and the resource that they need, and we coordinate that care for them.
Thank you, Danita. Ms. Newman, why doesn't something as basic and as logical as coordinated care exist on a wide-scale level? What are the holdups?
Well, I think there's several holdups. I think one of the problems is our value system as a country when it comes to healthcare. Our healthcare model is really based on profit as opposed to taking care of the population. And so it's driven by funding. So providing care for people who have who don't have access to funding, who may not have insurance, who live in areas where there are few providers, is going to be more difficult. And so because of the structure of the system, it makes it very difficult for people to access things as simple as care coordination services. The irony is that there's such a return on investment if we put more money systemically into prevention, care coordination, early intervention, we would prevent people from having to use the more expensive forms of care, such as emergency departments and urgent care centers. Not only is it more expensive per person, you get a poor quality of care because of the nature. It's not designed to keep people well. It's designed to take care of an emergency. And so you're not getting the same quality of care. Therefore, people are sicker. Therefore, it's costing us more money. So it's a systemic problem that we have to kind of continue to do the kind of advocacy that we've been talking about these last 2 days to really get our legislators to understand that we need to kind of change the way we think about healthcare.
Thank you, Ms. Newman. Ronald, you, as a Director of Health and Outreach, you have been doing a really good job with giving us MOUs in the rural areas. Can you explain a little bit of how that translates over to our warriors, the actions of you getting those partnerships for us?
Thank you. And I just want to say that I work with a phenomenal group of people led by Tabitha, and I think we should give them all an applause, particularly the community health workers. So to answer your question, the MOUs provide visibility. In rural areas, as I move around the state, and I heard Dr. Powell being told, it's frightening to go to places not far from here and find out there's no care. You go to the departments of health, and they're responsible for like 13 to 20 counties, and they only have one nurse working in there. We recently went to Sparta, Georgia, and we were begged by the head of DPH to provide provider training for 26 counties. They didn't know we existed. Think about how that translates over to people out there that are out of here. And why? Because they've gotten used to not being able to ask questions. Our community health workers provide visibility. They provide an email address, a phone number, but they provide confidence to patients that there's somebody they can talk to that's going to listen to them and their caregivers. I don't think we talked enough about the caregivers, but it's a point of reference. And that's what the MOUs provide, Alex. MOUs provide visibility, and all of these places become resource centers in partnerships, and that has immense value.
Thank you, Ronald. The foundation has a new initiative in Richmond County that focuses on coordinating care. Tabitha, can you tell us more about this project and why it's so important?
Oh, there. So first I want to say, Bernal here is the kindest human I have ever met in my life. He is so kind. So if you guys get a chance to introduce yourself and meet him, you'll know what I'm talking about. He just has a pure, pure heart, and I love him to death. And we found his way by doing outreach and education. He and Dr. Powell together going out, and we're using Dr. Powell. We are using him to open up these doors of these long-standing historical relationships that he had all around. Every time we go somewhere, and I said, this is a foundation in Georgia, first say, you know Dr. Powell? Yes. You know Dr. Powell? Yes. I was talking to a lady, I think I was calling to get my tax removed or something. And she's like, oh, I was saying that this is a foundation in Georgia, came up on her caller ID. You know Dr. Powell? I said, yes. Oh my God, I've been trying to reach him, I don't know where he is. He wants, let me give you a cell phone number. She was so excited. So
I want just to talk about the importance of these two dynamos being together, going out, opening up doors, and then, of course, Danina managing all of the community health workers is a godsend. The community health workers are the lifeline of our organizations, right, Angela? They do so much. So if you can think about a social worker, that's a community health worker. If you can think about someone that you can talk to in the late hours of the night when you're having a problem, that's a community health worker. If you can think about calling someone, I'm homeless, I don't have anywhere to go, what do? I don't have enough resources, that's a community health worker. I am hungry, I need some food for me and my kids. The community health worker sometimes utilizes their own funding to go and purchase food for our sickle cell warriors, that's a community health worker. So when I think about, what was that question about Richmond County school system?
Yes.
The reason it's so important, we have to make sure that our children are not bullied. We have to make sure that our teachers are educated. We have to make sure that our systems are not creating a hostage environment for our sickle cell warriors when they may have jaundiced eyes, when they may be thin, when they are often sickly, when they are out of school for many missed days, when they are hospitalized. So this creates a huge foundation for us by being in Richmond County school systems and now having one school system like Atlanta Public School Systems open up another system for us. And so it is critical for us at the Sickle Cell Foundation to have every school system with the MOU so that we can go out and do what we do best, and that's advocate and educate on sickle cell.
Thank you for explaining that and going in even more into detail of how imperative Danina's work is and what Bernard and Dr. Powell are doing.
We just had a panel on mental health. Imagine that all day, every day, you are hearing from people that are crying out. Imagine the emotional toll that can take on you. So I want to make sure that if you are a community health worker, that you too have a therapist. You too are taking advantage of the sickle cell sanctuary services. You too are resting. You too have an outlet, because when you are hearing from people that are in desperate needs all day, every day, it can take on an emotional toll. And then we have to remember, you too have your own families. You have your husbands, your children, your day-to-day life, and right, you have loss that you go through. I know, Amy, you just lost your brother. And so when you have all of that combined with taking care of people who are really ill, it can be very, very heavy. So if I had all the money in the world, I would pay our community health workers more and more and more money, because they are the lifeline of the Sickle Cell Foundation of Georgia.
Can we just give a round of applause for all the community health workers out there? Whether you're in the room or not in the room, I know that that's a heavy job. So we do want to take the time to give you your kudos. Dr. Powell, why is coordinated care so important? And I want to know from a physician's standpoint.
You see, I'm ready to do it. Now, care coordination. As a physician, care coordination is extremely important. The day-to-day work of a provider doesn't allow us to have the time to do things for patients that we know are going to make a big difference. And it doesn't do us any good to write a prescription if the patient can't get it filled. You know, it doesn't do any good to put the patient on the schedule to come to the doctor if they don't have any way to get there. It doesn't do much good for a patient to come see us in their home. So the community health workers are extremely valuable in dealing with the social determinants of health. So health is not just coming to the doctor, it's dealing with all these other issues. It's having a safe neighborhood, having that access to food, and education. All of those things are going to go into the health. So we in our offices, God knows every God needs a care coordinator to help him with his day-to-day activities. We just can't do it. So the work that the foundation is doing is extremely valuable, and hopefully the community health workers will be rewarded and appreciated for the work that they do. Myself and Mr. Bridges, we spend a lot of time talking to the community health workers, and we're out there in the field, so we see what they're doing. And we see that they get a lot of positive feedback from the agencies and the health centers and so forth that they are serving. So care coordination is extremely important, and we as providers need to understand that what we do is just a piece of the puzzle. Now, the other parts are done by people who may not be physicians, nurse practitioners, PAs, or nurses, but their jobs are just as important as ours.
Thank you, Dr. Powell. Ms. Newline, how do we effectively convince hospitals, insurance companies, and state agencies to invest in care coordination for sickle cell warriors?
I think you start with what's important to them, which is what I said before. How can they save money? Show them how they can save money, how they can make more efficient use of their resources. So when you're dealing with hospital systems and you're dealing with providers, really helping them understand first how important their job is, and helping them understand that we both have a vested interest. We are both interested in this person being well, okay? You get paid, and we get the satisfaction of them being well. So that's kind of where we start in terms of this is what we share in common. This is what I can do for you. I can make your job easier because, as Dr. Powell said, clinicians can only do so much. They only have so much time. You know, you help them understand that people live outside of these clinical walls. You only have 20 minutes with them. So we have all the rest of those 24 hours that they have to navigate life. So this is what your community health workers can do. Help them navigate life so that they keep their appointments with you, so that they follow the medical regimens that you have them on, because you didn't put them on those regimens just to have a conversation. You actually want them to follow, that they can get the prescriptions that they should have, and that they understand the medications that they're taking. So that's one of the ways that you convince hospitals, you convince providers, by helping them see it's a win-win situation. We're going to keep these people out of your emergency rooms. So we provided a report to the legislators, I think it was, 2 years ago, Tabitha? 2 years ago, where we were able to demonstrate that we saved the state $500,000 by providing care coordination services. We saved them $500,000 because we kept those people out of the emergency room. And we kept them out of the emergency room by making sure they had providers, they had a primary care provider, they had hematologists, they were taking their medication, and they were making their appointments. So that's the way we do it, is by really helping them understand how important this is to them and how it's going to help them do their jobs more efficiently.
Thank you, Ms. Devine, for that. Danita, let's touch on community health workers for a bit. Tell us a little bit more about what they do and the kind of feedback you get from the community when health workers are involved in sickle cell care.
So we get a lot of good feedback when community health workers are involved with individuals living with sickle cell disease, especially if they're able to build a relationship with that individual and the caregiver. I've got many compliments on the community health workers, because many of them say, oh my God, I needed this support so badly. And many of them are struggling just to go to work and be able to take care of their loved ones or their child living with sickle cell disease with no support or little support. And so when a community health worker comes along and they're able to provide that additional support that the caregiver can't provide, or, you know, there's no caregiver that, you know, no one else may be able to provide on a consistent basis for the individual, it's a godsend for them. Like Ms. Newman stated earlier, they use community health workers as a great means of support. So if they need additional food for the house, and the community health worker may be able to go out and get it from the food pantry and bring it back while the caregiver's at work, you know, to provide food for the family. We also assist with applying for and renewing for SNAP benefits because we are community partners with the Department of Family and Children Services. So we can assist the family with making sure that the medical benefits provided by the state are kept up to date and active, making sure that any other benefits that they get from the state are kept up to date and active so that they don't go without it if they need it. We also, you know, as community health workers, they help clients get access to mental health services, one-on-one, and group therapy, especially now that we have opened up the Sickle Cell Sanctuary, the Wellness Center. We're able to offer that benefits for our individuals living with sickle cell disease, their caregivers, one-on-one, group therapy, as well as the community as a whole. So that's a great benefit as well. I've got many good reports from our community health workers. Amy Hayes is the guru of housing, and she helps our clients get access to housing. She's helped a lot of them gain access and made many referrals that for them to take advantage of what's available as long as they have an income coming in and can support themselves adequately. We work with Kizwana Lester right there in Columbus at Valley Health. She does a great job with our clients. She's also extended her service into Albany, where we have a great deal of individuals living with sickle cell disease that need care. And it's just been so beautiful the way the foundation has been able to expand our reach throughout the state of Georgia by way of the MOUs that Renal and Dr. Powell have been so steadfastly, it doesn't work, been procuring for the foundation. So it's just a beautiful sight to see.
And I'm so grateful that you ended up there because that leads into my segue for you, Bernard, Dr. Powell. How hopeful are you that we can make inroads in promoting a model of care coordination that other communities around Georgia and even the country can use to help the warrior?
Age before puberty.
So I wanted to know, how hopeful are you that we can make inroads in promoting a model of care coordination that other communities around Georgia and even the country can use to help warriors?
I'm extremely hopeful. We know that care coordination that's the way of the future. It's care coordination. With the foundation should be fortunate enough to have some great community health workers, and we need to do whatever we can to keep the care coordination needs to be reimbursed. I think that's a big battle right now to get them reimbursed and become an official member of the healthcare system. Hopefully that's going to come. I understand other states that's already been done, or you just got to work it out here in the state of Georgia. So as myself and Mr. Bridges move around the state, and we hear of the great work that the community health workers to do it, we're convinced that the care coordination that they're providing is the way we need to go, where you assisting providers in the complete care of the patient.
Mr. Bridges?
Thank you. So this young lady sent me to a place called Stowe, Vermont this past summer. And the first thing out of my head was, where is Stowe, Vermont? And did they have any black people? Stowe, Vermont. And do they have any black people there? Well, I get there, and the circumstances are kind of convoluted because I had to get through some arrangements to travel to the site. Because you go to Burlington, Vermont, and you have to catch a cab, and you ride an hour to get to Stowe, Vermont. Well, the first individual that I encounter is a gentleman from Ghana. And he sees that I've got my sickle cell tag on, and he right now starts crying. And he said, do you realize how many immigrants have moved to Vermont that have sickle cell and don't have any place to go? And he was so overwhelmed. I gave him information. Dr. Wally Smith, who is a well-known practitioner, did house calls during the conference. There are people moving into these sectors of the country that need the help. And as Andy talked about so profoundly, we have to be visible. When I got to the conference, the first thing that came up was care coordination. How can we shift investments for this? What is it? Pfizer, Novo Nordisk, all of them were asking questions about how they can realign resources around care coordination itself and the community-based organizations. So they're just at a point where they're learning these things. We have to step up and educate them, get them engaged, but we have to stay in a continuous dialogue in order to make a difference for the people that need the help, because it's out there.
Thank you for that story. I think that gives a little bit of insight outside of the perimeter of Georgia, just on the larger scale of what health disparity looks like. Yes, we understand rural areas, but I think a lot of times we're so caught up in where we are, we don't really think about what's happening even on a national or global level. So thank you for that story. This will be the last question, and then I will open the floor up for anybody who has a question for our panelists. And this question is for our boss lady, Tabitha. I'd like to give you the final word here. What is the big takeaway from this panel discussion that you really want people to be aware of?
Is that care coordination is one of the founding blocks of our organization. That community health workers are always on the top of my mind and in my heart, because I know what it's like to take care of someone that's ill, because of course, resigning from corporate America and going home to take care of my son and being his sole caregiver, it's a lot. It's a lot when you are fighting against the system of healthcare where racism is involved. And so when my son died, I realized that it was me solely providing for the care of him, and I just wish I would have had help like a community health worker. So they are so vital. And let me say this while I'm at it, not just our community health workers, but we have some partners here today. Angela Shepherd, can you stand up and say hi? Lois Williams, can you stand up and say hi real quick? Crystal Stone, can you please stand up and say hi real quick? Dolores Mitchell, who is in Hyattsville, and Mapilla Dunn, who's in Clayton County, unfortunately, not here with us today. It takes a network and partnership and collaboration in order for us to make sure that individuals with sickle cell are living well. We cannot do it alone. I can't do it alone as a CEO. I have to have
my organization, my staff, my partners. Thank you, Pfizer, thank you, Agios, me, Terumo, all of our partners. Thank you, because we need the funding in order to take care of our sickle cell warriors. We need the funding for care coordination, so we can provide them with the essentials that they need, like food and like rental assistance. And thank you, Pfizer, for your transportation program, because it has literally given hundreds of rides, like Danina, from people to get from home to the sanctuary for services or home to their pediatrician or their hematologist. And most importantly, before you leave the great state of Georgia, going to college, going to work somewhere else, make sure you talk to a community health worker so you'll know what your options are by way of sickle cell care before you get to another state. Because you go to another state and you find out they don't know anything about sickle cell disease, so you have to be educated, right? And then we want to make sure that we start teaching them as early as we can about the importance of their own care, because parents have a tendency sometimes to be very coddling when it comes to their worries. And we understand that, because I'm a parent. I was very coddling of my son, Melvin, because he was sick. I'm like, did you take your medicine? Did you have your backpack? Have you taken your blood pressure this morning? Have you done all these things? And then when he turned 18, before he turned 18, he's like, I believe you just leave me alone. I can do it myself. I'm like, well, okay. So we need to start teaching them younger so they can have better care. And I just want to say thank you to all of you all, because in this room together, that's what care coordination looks like. Because every last one of us have a part in it, right? None of us can do it alone. And so that's what care coordination looks like. Alex is one of the building blocks inside of the foundation. And I see that we can replicate this model all over the United States. And then, Alex, people have to understand, just because we're in Atlanta metropolitan areas, do you know that there's places like Clayton County that don't know anything about sickle cell? Do you know you can go into Decatur and can't get great care for sickle cell? Do you know you can go down to Henry County and not get great care for sickle cell? So don't let people be fooled that just because we live here in the state of Georgia and the Atlanta metropolitan area, that there's great care for sickle cell. Because we're finding out through provider training, right, Doc? Right, Bernal? Right, Jeanette? We're finding out that many providers don't know anything about sickle cell. And not only are they not educated on sickle cell, they don't want to know. Because they are not getting paid well to treat sickle cell, but I get paid 10 times more to treat oncology. So we have a huge problem in front of us, and we have to speak about it, be confident about it. You know how I spend my free time? Educating myself on what's going on in the healthcare space, particularly sickle cell, what people do know and what don't they know. So we just signed a new MOU with Emory Hillendale. We went up there and they said, we can't wait because we don't know anything about sickle cell. Please come and help us out. Right, Amy? Right, Danita? Absolutely. Yeah, so we got a lot of work to do, and I am praying that they do not cut our budget. And I'm gonna do everything, because what they look at is, I'm giving you money, but they're not. We're saving the state money. We're saving them money. They're not giving me anything. I am saving them money by keeping our warriors out of the hospital and out of the emergency room visits.
Say it one more time.
We're saving them money, Alex. They're not giving me anything. We're saving them money. Bill Robinson just came to us and said, since 2023, I have not been hospitalized, and I have not had to go to the emergency room. And oh, by the way, when I have a crisis now, I can take a Tylenol because I'm using the sickle cell sanctuary. So they're not giving us anything.
Okay, we'll be here all day. We are all I think that's one thing we can say about those who work in the sickle cell community is once you get us riled up about something we're passionate about, it's gonna take, I'd say, a big chunk of change to get us to stop talking about it, because we just have a bird's eye view of knowing what it takes for it to get better, and it just seems so incredibly unfair that people with sickle cell who are not born with this disease, who are born with this disease, you can't catch it. It is something that is genetic, and they seem like the crumbs. It's just not right. So, I'm gonna open the floor, because we were here all day. Ask us a question, yes, Latoya?
My question is, where can we find this incredible data that you shared with us about cost savings? Because we know the numbers like that speak, so how can we activate us with that information to build the thought?
So Jeanette Newman that's sitting right here, she's responsible for all of our data. And so when the sickle cell warriors are coming to our sanctuary, we now have a intake form, and we're asking those questions on the front end. When was the last time you went to the hospital? When was the last time you was in the ER? And then from there, we can take that data and collect it. And I have asked Jeanette to give me a white paper, and then she put her vacation in to go to Cutler for 30 days.
Well, I need the data from one. So I've asked Tabitha, and I've asked the sanctuary, and I have asked Dana, I need data if you want me to put together a white paper. But also, the costing data you can get from Angie's group. So she can tell you, because we took our data, the number of people that our CHWs were able to get into care, and then we got from Angie the costing of what it costs for somebody to go to the emergency room versus what it costs for somebody to go to a provider. And then that's how we did the calculations.
So we would have our paper published very soon, so we will get that evidence that we need. And then we go from there, because it's not enough out there
About it, right? And so when we're going and looking at the National Institute of Health, right? And so they have the integrated section there. They talk about holistic care and acupuncture, massages, and what it does. However, they're the only ones that have anything out there published. So it's up for us, because we are now following in those footsteps to bring this information to light. We are going to have to write our own white papers.
Yeah.
And we will. We'll have a lot of data to publish very soon. We've only been open for a year, so it took some traction for it to turn on. And even now, we're still advocating and promoting. If you have sickle cell, come to the sanctuary. It's just that simple. Come to the sanctuary. We're gonna take great care of you. We're not gonna make you wait in a waiting room for 15, 20, 30 minutes. We're gonna get you in as soon as you sign your name. And so we want more and more of our sickle cell warriors to visit the sickle cell sanctuary. We have a hematologist, we have a nurse practitioner. I think we have now 3 registered nurses. We have 2 phlebotomists there, and we're still expanding our services. Next year, I'm looking at apheresis inside of our sanctuary. I'm looking at pain management inside of the sanctuary. So it's still growing a number of services.
Any other questions from the audience? Okay, thank you to our panelists and my coworkers for sharing with us this very, very important information. It's been wonderful having you up here and sharing this day with me. Thank you. Thank you. Thank you, ladies and gentlemen. All right, moving right along. We all know that one of our biggest problems in the healthcare system in the United States is affordable healthcare and affordable prescription drugs. Yesterday, we talked a little bit about 340B drug pricing program and how it's not achieving what it was designed for, which is reducing drug prices for vulnerable patients. Melissa Bishop Murphy walked us through this in a presentation yesterday. And guess what, guys? We got her back again. Thank you so much, Melissa, for coming back and to talk more about affordable prescription drugs. If anyone knows a thing or two about prescription drugs, it's Melissa. She is the senior director, let's put some respect on that. She's the Senior Director of National Government Relations and Multicultural Affairs for Pfizer Incorporated, with more than 30 years of lobbying and alliance development experience on the state and federal levels. Melissa currently lobbies in Georgia, South Carolina, North Carolina, and Puerto Rico. And additionally, works to build multicultural coalitions to advocate for greater access to healthcare and pharmaceuticals nationally. We welcome back Melissa. Thank you so much for sharing your experience.
Yeah, let's give Alice a round of applause. She's done a great job over the last 3 days. From the panel, this morning in regards to safeguarding reproductive health, to this panel in regards to care coordination. I think that the resounding thing is that we have to create our own system of access to care. That you have to be an advocate for yourself. Because when we talk about it, about access to prescription medicines, there's just not one single entry into affordable medications. So I will talk to you today about Pfizer's drug donations program. I'm going to talk a little bit about state and federal programs. I'm going to talk about an organization that you may or may not be aware of. But what I will say to you is that the community health worker, the care coordination team, if you have questions, if you go on that road, please feel free to reach out to me afterwards, because there's just not one central point of care to get affordable prescriptions, which is so unfortunate, because I do remember having been around over 30 plus years doing this type of work, that at one point, PhRMA, which is the trade association for all of pharmaceutical manufacturers, had a program called Together RX. And so you would just call this one number and you could then access all of the pharmaceutical drug donations program from that. But since Medicare Part D happened, that's just not the case. So you have to call each individual drug manufacturer. So let me talk to you first about Pfizer's program. Although Pfizer no longer has a medication that directly treats sickle cell disease, we still have other medications that people living with sickle cell may not use. And you can access those programs through Pfizer's RX Pathways program. Pfizer RX Pathways provides our medications for free or at reduced cost. It is based on the amount of money a person has. And so, you know, the key to the Pfizer program is that you have no insurance, or you are underinsured. So your medications are not being paid for by an insurance company. Pfizer also has a digital program, because we heard about care coordination. We realized that accessing the Pfizer medications was just not enough, that there were other parts of the social determinants of health that people taking Pfizer's medications were facing. So we have a program called Pfizer for All, and anyone can access this program. It's a digital platform that simplifies access to various healthcare services. So in addition to getting access to medication, Pfizer for All offers services by connecting patients with healthcare professionals, scheduling appointments, finding and booking vaccines, and providing access to COVID cards and other affordability programs. So we wanted to create a platform where you could get that care coordination, not just accessing the medication, but certainly given the superstar teams that you all have, you may not need Pfizer for All, but for those who might need it, we do have that digital platform that will help you coordinate your care. In addition to Pfizer's programs, all pharmaceutical companies have some type of drug donation program. And so when I talk about drug donation, I'm talking about getting the medications for free or getting your medications paid for at reduced cost through a co-pay card program. So I know that a number of people may be insured, but you can't pay for that. You know, think about hydroxyurea and the costs around that. You need some assistance with bridging for that co-pay. And so Pfizer offers copay cards and other companies do as well. So that is another way. So again, it's fragmented, but again, finding a way to pay for these medications to make them affordable, those copay cards come in handy. From a national and state level, there's a program called Serum, SIRUM. This organization matches donated medications to community partners who then provide to patients who otherwise wouldn't have access. So this program is in Georgia. I don't know if you all have taken advantage of it. What happens is medications that has not been adulterated or not open comes back and is redistributed out. There's also a state-run drug depository program here in Georgia, and it's run by the Georgia Department of Public Health. I don't know if you're aware of that program as well. And then finally, here in the state of Georgia, we have the SafeNet RX. It's a nonprofit that collects and distributes donated medications to help solve the medication inequity. Again, fragmented, but these are ways to access medication. When we talk about disease-specific programs, there's the, and I may pronounce this wrong, Bactacine program. Is a drug donation program for those who are taking sickle cell disease medications. It's mainly in developing countries. I heard the doctor talking about Stowe and the fact that there are people coming from other countries who are living with sickle cell and not having access to their medications. So that's more of a global program. I know that Merck, who also has a program specifically for those who are living with sickle cell disease. There's also the Sickle Cell Disease Cures Consortium, which provides, may be able to provide that financial assistance, right? So there's other ways you may get the medicine for free, or you may get some type of financial assistance, and that's how the consortium works. What I will say to you is that there's another wonderful organization called the Patient Advocacy Foundation that Pfizer works with very closely. It's a national 501c3 not-for-profit organization that provides case management services and financial aid to Americans with chronic, life-threatening, and debilitating diseases. And they also offer, I'm going to call them scholarships, but they're financial assistance. So financial assistance to help pay for medications. And then I really wanted to, as I was talking to a former Grady case manager who's in the audience, we got to talking about hydroxyurea and how expensive that is. And BMS makes the branded version of that drug, and makes BMS stands for Bristol Myers Squibb. I'm sorry, we sometimes get into the acronyms and forget this spell out the full name. But Bristol Myers Squibb does provide a drug donation program for hydroxyurea, and I'm sure all of the care coordinators here know about that. But I wanted to make sure the audience was aware that particular manufacturer does provide the branded hydroxyurea medication as part of their drug donation program. So with that, I will stop and take specific questions. But again, because this is a fragmented way of accessing medications, always feel free to reach out to me. I see some of my colleagues out in the audience with other companies. I'm sure they'll be happy to also talk about their drug donations program. We know that drug donations programs are so important going forward because so many people are no longer Medicaid eligible. And so we want to make sure you know that as far as Pfizer is concerned, our drug donation programs will always be around. They've been around for 27 years. I've been at Pfizer. We've changed the programs to respond to the times. Prior to Medicare Part D, we used to offer all our medications to seniors for $5. So I don't know if we're getting back to that given the times we live in, but certainly Pfizer believes that everybody should have access to its medicines irregardless of ability to pay. And so that's really our bottom line, and so we adjust our programs as necessary, but right now we have the Pfizer Arts Pathways Program and the Pfizer at Home Program. I'll stop now and take questions. Yes?
Can I get that list of all of those?
Yeah,
Make sure my
absolutely.
community, health workers have it, because that was really powerful, and I don't know if we're familiar with all of those different.
I'll send you
donations
a
programs.
presentation.
Thank you. When it comes to Pfizer, well, you know,
Oh, no, you go ahead and ask, we're amongst family. You know, what I would say about Pfizer, as you tap them and working together for a couple of years now, no company is perfect, but we want to always have the ability to communicate with one another, but open door policy, so go right ahead.
so with that being said,
Yes.
we know that one of the drugs got pulled off the market.
Yes,
And I know you guys, I'm sorry, you guys are working, but that's it all, that's what
Yes.
it's called as well. Okay, so I know that's done. Do you see the light at the end of the rainbow that another drug will be coming soon? I know that Pfizer is still in the space, and I thank you for that, because I know you guys are still here with us, you haven't left us. But do you see that we will have something from Pfizer very soon on the horizon? I mean, what's the forecast?
So what I would say to you is we're continuing to work on something. So, and we're also working with, the regulators in terms of figuring out can Ospirita be brought back in some form or fashion. So those conversations continue. We really want, as a company, to be able to deliver a product in this space. We really do. The team, the rare disease team, they bleed for you guys, I'm telling you. Everybody is always so upset when we have to pull a drug from market, but safety is always leads with Pfizer, so it's, therefore the safety concerns. But certainly they continue to work in this space. Yeah.
Is there any way Pfizer can help out the sickle cell sanctuary with COVID vaccines? Is there a program that you guys have that we can purchase COVID vaccines less expensive than we're paying for right now?
Let me find out. Certainly, we are always looking for opportunities to be creative. And certainly, I think that might be an opportunity. So I will work on that for you.
Okay, because there's a lot of people right now that have COVID and the flu again is going back around.
It is.
So I wanted to know that, so the sickle cell sanctuary.
Yeah. Any other questions? And I offer my other colleagues, but might want, from other companies who might want to speak about their drug donation program, speak up if you want to. But no pressure. All right. Well, again, always feel free to outreach to me. We do have patient, we have employees that work to help navigate the system that can work with you. And unfortunately, my colleagues in that space couldn't be with us this afternoon, but certainly happy to connect you to them. I know Tabitha, you met with them as well. All right, thank you.
Grant is going to be awarded.
I don't, but I can find that. It's going to be shortly because we have to get the money out the door this year. So it'll be this year. Yeah, yes, ma'am. I think behind you, looks lazy, but. Oh, I'm sorry.
If you would, please explain the zero, the SI.
Yeah.
Program again, and also where can we find the link for these,
I I'll give them to you. And Zero Park is a Georgia program, so let me just, am I getting your name here? Okay, Kathy will send it out to you. It's SIRUM. But I'll send the presentation to Tabitha, or I can send it directly to you as well. And it has links to all of the things I mentioned, so you just have to click on it. And I'll take you there.
Can you take about 30 seconds to describe that program?
Okay, it is a program where people are donating their unused medicines back to the state, and then the state will distribute it out. That's a lot.
So it's no explanation.
They wouldn't distribute it, it's fine. Yeah, because it's It's a safe program, yes.
So, do you know, like, if you have a lot of
Prescription drugs at home and you no longer need them.
You can take it to this program.
Oh,
Yes,
wonderful.
yes.
That'd be a place.
And in fact, this was, I remember when this law was passed, and this was one of the efforts, passed about 10 years ago in Georgia. Because the legislature was wanting to try to figure out some way to make sure that, drug costs were reduced and all of that. So that they created a program and a policy to make sure that there's a way to get those drugs. Yeah. I'll send that to everybody that wants it. Anybody else? All right then. All right, thank you so much.
Thank you so much, Melissa, for that information. I am sure we are very interested and eager to learn how we can get that information and make it accessible for our warriors and so on. So next we have a speaker that I would like to say a few words about. We all know how difficult it can be when a child or a family member is sick. For sickle cell warriors, staying healthy is a constant battle, and their families often serve as caregivers, advocates, and of course, loved ones. Sometimes the stress of caregiving is overwhelming, but you may not realize there are programs that can help. Jennifer Melton is an Atlanta health provider specializing in nursing care. She works with IntegraCare, a company that provides in-home care for medically fragile children. So many people may not realize this care could be free to them if they're on Medicaid. But let's let Jennifer tell us more about Medicaid in Georgia and how we can help sickle cell warriors and their family. Please join me in giving a warm welcome to Jennifer.
Hello. Hi. Good afternoon. My name is Jennifer Melton, and I am the CEO and a pediatric home healthcare agency here in Georgia called IntegraCare. We proudly serve medically fragile children across our beautiful state. And today I'm honored to speak with you about how Medicaid serves Georgia's children, and in particular, about a program called the Georgia Pediatric Program, otherwise known as GAP. This program provides essential in-home nursing care to medically fragile kids. As decision makers, legislators, and policy influencers and advocates, your choices shape both the health and the economic future of Georgia's children. My focus today is threefold. I will first talk about the current landscape of children on Medicaid in Georgia. Second, I will discuss the GAP program for medically fragile children. And third, how our agency, IntegraCare, offers and participates helping families navigate through all of these systems. So, in Georgia, Medicaid remains a cornerstone of children's health care coverage. A recent analysis by Georgetown University shows that in 2023, the percentages of children enrolled in Medicaid or Peach Care ranged from about 26% to over 60% by county. These rates vary dramatically, especially in rural and underserved regions, which is constantly showing the highest enrollment rates. Families encounter several obstacles accessing Medicaid programs. The first being awareness deficit. Many families simply don't know that programs such as GAP and Katie Beckett even exist. The second is many families experience a delay and denials due to incomplete applications and lack of documentation. Families may face transition challenges for young adults aging out of the system at a certain age, 21 years old, and sometimes they lose vital support while waiting adult services. Complex recertification, enrollments, all these processes are especially difficult to families, especially the Katie Beckett waiver. Families often describe the paperwork as being long, confusing, and discouraging. The last and most common obstacle that families face is rural disparity. There are fewer providers outside of the city limits that actually offer these services, which often discourages participation. Okay, I'm missing a slide here, but I would like to say the Kaiser Family Foundation in May of 2025, currently they are reporting that Georgia currently has approximately 2.24 million people enrolled in Medicaid, and children make up 55% of all Medicaid enrollees. That statistic alone underscores why legislative and attention to pediatric programs is critical, because when we strengthen pediatric care, we strengthen the health and economic stability of our entire state. As a data-driven professional myself, I believe in collecting and analyzing metrics such as rehospitalization rates, quality of life indicators, and family satisfaction, which provides evidence that's needed to justify continued investment in these programs and to inform policy decisions that are grounded in real-world results. So now, why specialized programs matter? These specialized programs matter because for obvious reasons. Of course, hospital-based care for medically fragile children is extremely costly. Often it's about $3,000 to $5,000 per day. Comparable to the GAP in-home nursing services, it's only about $400 to $600 per day, depending on the hours and the skill level of the nursing. Yet the benefits go beyond cost savings. Georgia Medicaid reports that children in the GAP program have about 30% fewer hospitalization readmissions in the first year alone, higher family satisfaction, and better continuity of care. Additionally, nurses build lasting relationships with families, so that's a plus. And medically fragile children often require complex 24-hour care. Without in-home support, families face frequent rehospitalizations and caregiver burnout. From a policy perspective, investing in children's health is both a humanitarian imperative and a sound economic decision. Healthy children have a better chance of becoming healthy and productive adults, reducing long-term institutional and healthcare costs. So these are the programs available for children on Medicaid. First, we have the Katie Beckett waiver, which allows children with significant medical needs to qualify for Medicaid based on their disability rather than their parents' income. So once the child is eligible for Katie Beckett, they have access to all the standard Medicaid programs and benefits, such as the Georgia Pediatric Program. GAP specifically is designated to help with in-home skilled nursing, such as RNs, LPNs, and personal support services as well for children. Then we have EPSD, and EPSD offers preventative care, basically like making necessary screenings, treatments, from birth to the age of 21 years old. Last, we have the Now Comp waiver. Basically, that's a Medicaid waiver, and it offers community-based support for children with, children and adults with developmental disabilities. And often it serves as a complement for GAP after the age of 21. So what is GAP exactly? The Georgia Pediatric Program is administered by the Georgia Department of Community Health. And it serves Medicaid eligible children under the age of 21 years old who need skilled nursing and personal care due to complex medical conditions such as, things like trachs, vents, seizures, tube feedings, ongoing pain management, and etc. This program shows that Georgia recognizes the need for specialized high acuity pediatric services beyond standard Medicaid coverage. This program supports several different areas. It supports care coordination, skilled nursing services, family training, and service planning, additionally transitional support. It matters because it reduces hospitalizations and emergency room visits through preventative care and early intervention. It allows children to remain in their home and promotes better psychological and developmental outcomes. It creates cost efficiencies compared to institutional care. It promotes family-centered care so that children thrive at home. So, the type of services under GAP include in-home skilled nursing care, which includes RNs and LPNs, skilled nursing, providing specialty care for things such as I said before, vents, trachs, tube feedings, medication administration. It also provides personal support. The acronym is PSS, but it's non-medical care, such as bathing, feeding, hygiene, and light housekeeping. Under personal care support, we have the caregiver option, which was just available since last year. The caregiver option, basically it trains a family member to be paid as for personal support services. We also have behavioral support as well. It sends out behavioral aids pretty much to provide in-home therapy for children with behavioral needs. So the application process, families who apply have to have children under the age of 21. They have to be Medicaid eligible and in need of skilled nursing or personal care. A physician plan of treatment is required by the child's primary physician, and applications may be submitted through an approved GAP nursing agency or a hospital discharge planner or a case manager. But that being said, families cannot apply on their own, okay? So authorizations are reviewed by the Alliant Health Solutions and typically approved within 30 to 45 days, which is remarkably efficient compared to some of the other programs because KBEC can take a year or more to get approved for. It's a very difficult application process. So this is probably the fastest and most efficient program in Georgia. As far as recertification, it occurs every typically 3 to 6 months with an updated PPOT, which is a physician plan of treatment, and also clinical notes. The agency will have the RN conduct supervisory visits, skill validation, and ongoing caregiver education. Emphasis is placed on documentation, incident reporting, compliance with Medicaid policy. And this oversight ensures constant, safe, and high quality care. Medicaid is a foundation for safety net for Georgia's children. As you can see, over 55% of kids are on Medicaid here in Georgia at this moment in 2025, and that rate seems to be rising. The program like GAP, uniquely fills a crucial niche in Medicaid for medically fragile kids. At Integra Care, we're proud to partner with the state and serve this population. Help, us reach and serve more children by becoming our community partner. We would love to be happy to come in and introduce ourselves to your team or simply drop off informational flyers and figures in offices. Even the smallest actions like this can help families connect to the care that they need. Our children are an investment in Georgia's future. Healthy children need stronger families and a healthier economy at the end of the day. On the referral side, our agency manages the entire application process for families, from gathering documentation to working with physicians and Medicaid reviewers as well. Ultimately, collaboration means ensuring that no child falls between the cracks simply because a parent doesn't know that the program exists. And so this is our information. Integra Care is committed to delivering high-quality in-home care for children with complex medical needs. And our mission is to ensure that every medically fragile child has access to skilled nursing and personal support aligned with Georgia Medicaid programs such as GAP. And I welcome any questions you have, our partnerships, and your leadership as well. Thank you so much.
Great job. Can a person be a Katie Beckett for purposes of income when qualified for the pediatric program?
Absolutely. Okay. As soon as families qualify for Katie Beckett, they immediately qualify for GAP.
Can you be GAP and not Katie Beckett too, though, right?
You can. Okay. You can be GAP and not Katie Beckett. Yes, absolutely.
And the reason I bring that up, you guys, is because I was general counsel with Medicaid.
Oh, okay.
There are families who, you have to not make part of the money to be Medicaid eligible. So Katie Beckett allows a person to be a family of one, so the child becomes a family of one for financial purposes. And then the child doesn't have any income, so of course then he or she becomes eligible, and then he or she can get into the Georgia pediatric program. So that's just what I used to see happen. I don't know if this still goes on, but a lot of people become Katie Beckett first, and then they're able to qualify.
Absolutely. Yes.
So what types of conditions are considered medically fragile?
All across the board. I would say if your child, a lot of times the barometer is if the child has an IEP in school, because that is necessary in order to qualify for the program as well. So they have to have an IEP. Also, the child has to be on some kind of medication. Like, they need to have a reason why they will have nursing care in the home. Families can reject the nursing care if they want and just take personal support services, but they have to qualify for some sort of nursing care. That means medication administration for any type of reason, or they have machines that they depend on for their life and well-being every day. Yes.
I was just going to say, under EPSDT, which stands for Early Periodic Screening, Diagnosis and Testing, that is a government law that basically says that children should have any medically necessary services.
Yes,
so that pretty much opens the beginning.
That is the root for all the Medicaid programs, that program as well. Yes, ma'am.
To simplify or to break it down, A medically fragile child would be a child, born prematurely. They are unable to breathe on their own, so therefore they have a trach. They require a vent. A child that has, any type of digestive problems where they can't take food in orally, so therefore their only nutrition is a G-tube. There's cerebral palsy,
Traumatic brain injury.
traumatic TBIs,
Muscular dystrophy.
Yes.
It can be
Children that have seizures. Everything.
Although I've seen some kids with cerebral palsy been denied. Yeah, I don't want to go too far down that road. But parents, the more they seem to discover this program, the more the Georgia Community of Health seems to be denying kids more and more kids. That's just what I've seen. I saw a child get denied GAP because he had cerebral palsy, but in his IEP, it mentioned that he could kick a ball. And so for that reason, he was denied.
So I guess you basically say a child that is physically or even mentally delayed. And so they don't progress across the normal stage
Right.
of development.
Unfortunately, though, I would like to, thank you so much for that, I appreciate it. Unfortunately, I would like to kind of, just a little bit more information on that. I've seen developmental delay on its own does get denied. Unfortunately, because they think those children are independent, they can grow up to be independent individuals in society. So that would not qualify under GAP.
We have to specify
What physical limitation that they have. Exactly.
Because I was gonna say with the denial, usually there is the appeal process, and I would think an administrative law judge would look at the totality of that evidence. Just beyond getting involved.
Oh, I wish we did.
Right, exactly.
Yes.
That's right, because the OT also functions on mobility and cognitive.
Exactly.
And if they can't, sure, I think, then they're.
Right. Exactly. Any other questions? Well, thank you all for having me. And
This is the most awkward microphone situation that's on. Because if you have your tablet, I get the. Well, everyone, the time has come to wrap up this excellent conference. Let's give ourselves a round of applause. On behalf of the entire Sickle Cell Foundation of Georgia, all of our guests and speakers, I want to say thank you for being part of these dynamic discussions over the past 2 days. We've heard from amazing speakers and experts. We've discussed extremely important issues for the sickle cell community. We've gotten a first-hand look at how to turn a goal, some might say a dream, into real legislation, and then finally law. We know what successful legislation action looks like. Remember, we are not just sickle cell warriors, advocates, caregivers, or medical professionals. We represent the thousands of Georgians battling sickle cell every single day. More than 16,000 of them who are navigating pain, uncertainty, and barriers to care that most of us can't even imagine. I want to pause right there for a moment. I want everyone in the room, just think about if you've ever had a toothache. Anybody had a toothache? Raise your hand. Imagine that toothache multiplied by 10 over your entire body for days. And there is nothing that can stop that pain. I don't think most of us truly have the empathy or the compassion that we should for sickle cell warriors. So just imagine that for a moment. That's what we're fighting for. Equitable processes, policy, laws, changes, so our sickle cell warriors can at least feel well. I want to make sure we all understand one goal that we have is to help them feel well. Y'all got it? Do y'all really have it? Okay. I get so passionate about it because we get to see every day, right, Pat, our bird's eye view on what a day in the life of a sickle cell warrior looks like, because I have 4 on my staff. We don't fire them. We don't take away the PTO. We don't take away their money when they're hospitalized. So if you're sitting here today and you have the opportunity to hire a warrior, do it. If you have the opportunity to adopt a warrior, do it. Let me talk about what adoption looks like. It's not just finances. Maybe it's taking a warrior to hospital when they're hospitalized. Maybe taking them a meal when they're hospitalized. Maybe it's going to their house, checking their mailbox. Maybe it's taking them some food when they're hungry to their home. Maybe it's helping pay a utility bill so their lights don't get cut off because they lost their job, because they missed too many days, because they have sickle cell disease. Maybe it is financial. Maybe you could set aside that $50 or $125 for getting your nails done to give it to a warrior. Just maybe. That's what adopt a warrior looks like. I have a warrior that I've adopted. Most people think he's my biological son. His name is Blaze Aperture. Tomorrow, he's been hospitalized. On Wednesday, he's having open heart surgery. I will be there. That's what it looks like. If you really want to cause change, you can't ask other people to help you if you are not a part of the help. So let me get back to my speech. And for many sickle cell warriors, their disease seems invisible. They may look, sound, and even manage to act fine as sickle cell disease ravages their body and even their mental health. But this conference proves sickle cell and the warriors who battle it every single day are not invisible, and neither are we. They've heard our voices down at the Gold Dome. They've seen us in action. But here's the truth. While all change is possible, real, lasting change starts with policy. It means vital legislation, action, and changes in laws that help enable access to care, supports research, and helps sickle cell community live dignified, healthy lives. And that change starts with us. Those of us in the room at this conference and in the halls of our state capitol, every bill we pass, every update to healthcare law, every dollar earmarked for sickle cell care is a heartbeat of hope for someone living with the disease. We have the power to speak up and speak out, to make our voices heard, to advance legislative measures and policies that would directly impact lives, to hold our leaders accountable. If you have not had a meeting with your representative in your city, do it today. I have an email from my representative, because I email her all the time. This is what I need. This is what I need you to do. Can you come and see me? I want to talk to you about this. Here's a new, conference that we're having. Here's a new warrior that needs help. What can you do? Are you for us? Are you opposed? He's like, I'm for you. What do I need to do to help? All of us have that power if we bug the heck out of it. I'm a bugger. Change is coming. Do you know why? Because we're bringing it right here and right now. Let me read that again. Change is coming. Do you know why? Because we're bringing it right here and right now. As I look at my pretty baby, Keesalon White, sitting before me, that although she's battling sickle cell, she just lost her fiance and her grandmother. So guess what? They still have everyday things happening to them as well. I love you, Keesalon. So I look and I want to challenge you. Help us create the momentum for change and to keep it going. Every conference, you should bring in 2 and 3 people. Don't just show up alone. Bring somebody. Help us create the momentum for change and keep it going. Help us by committing to a very few basic principles and actions. Speak boldly. I know some of you already do. Advocate tirelessly. Again, I know so many of you here are here with us in the fight. Stand up for those whose voices are often unheard. Every bill we pass, every policy we improve is a bright ray of hope for someone living with sickle cell disease. Please come out with us and stand with us on our day of legislative advocacy at the Capitol in February. Last year, about 400 of us that read the blood of Jesus was just all over the place. So in February, when we stand up, stand out, and ask, no demand, the changes we want for sickle cell warriors to live their best lives. We cannot wait. We cannot hesitate. The time is now. The voices are here. And the change, you may ask, it's ours to make. Nobody else is going to do it. We have to do it proudly and boldly. I need you to join me, join my hand, join forces to make a difference. We won't wait any longer. I'm not concerned about money being cut next year. I am creating opportunities and outlets for money now. So I'm not sitting around worried about what the administration is going to do. I am only focused on what I can do now. So guess what I can do now? Write other grants, go looking for other funding from corporate sponsors, from other pharmaceutical companies, create new relationships. We don't have to wait for them. Do we, Dr. Person? The time for waiting is over. It's time for action, people. I want to say thank you so much for every single person that stood on the stage. I hear you. I know you're committed to this cause. I thank you. I thank you for your partnership, Angela. I thank you for your partnership, Crystal. I thank my sickle cell warriors for keeping me humble and making sure that what stays in front of me and on the forefront of my mind every day is not my little problems, but a bigger problem in front of me that we can bring change to. I thank you to my staff for your support, for believing in the vision and the mission. Jackie, you give a whole new word to this organization when someone knows that you've been here at the Sickle Cell Foundation of Georgia for 47 years. And she's still serving, she's still fighting, she's still educating, she's still doing blood testing. And you remind me of what passion looks like, of purpose. So thank you, Jackie, for being that example for me to not give up when it gets tiring. to not give up when others have, to not look away when there's a problem, but to look that problem on directly. Thank you, staff. Thank you, team. Thank you, guests, for joining us. I really appreciate each and every one of you. Thank you.
Guys, please don't go anywhere. We're gonna have a wellness demonstration in the back as we flip this room, and I invite you, let's break bread together. Let's sit and talk and network, and let's take this conference out with a bang. We have some delicious food that they will be serving for you today. So please, do not ring out that door. I know we're ready to get our weekend back, but please stick around as regular. Huh? I'm talking about the guests. Yes. We want the guests to stay. So if you are not employed by the Center Foundation of Georgia, and you